Perfect. Okay, so greetings everyone and welcome again. I'm Professor Riggs and today we are going to cover cardio. So this is all adult cardio. So last session we've covered the anatomy, physiology, the diagnostic tests for this system for cardio and all of the pediatric cardiac anomalies. So this is all about adult disorders. So just a reminder, remember every day you're off, depending on your schedule, you want to target a client needs category. You are going to watch the recording, do the questions that is on the PowerPoint, with me during the recording. And then there's exams afterwards for you to take. And then please don't forget to remediate your exams. That's the important part. So some things are in what we call learner mode. Learner mode is where you get question, answer, because you're learning. And then there's exams that are in tester mode. So tester mode is for you to really show that you have enough content, that you are above benchmark. So whether you did well or not well, go over the question and the rationale. If you have time, all of them, not just the ones you got correct, go over what you chose, what the correct answer is, and why. They all have rationales to them. Only the pre-diagnostic tests don't have the rationale because there's a purpose for that. It's just to see where you are on the benchmark, but everything else have the rationales, okay? So go over that. Now, at the very end, once you've gone through all 8 client needs categories, there are select all that applies. There are hundreds of them, and I've broken those up into 50s. So literally give yourself a few hours to do like a 50 SATA, select all that apply, and then go over the rationale. You have to remediate. So, and then the next generations also will be at the end. And here's the reason why. It's best for you to build content in these client needs categories before attempting the select all that applies or the next gen subjects. Because when you, for the select all that applies, that is what they're testing. They're testing to see how well you know content. So it's best to go through the material, learn it, and build content. The next generation with the clinical judgment model, it builds where you have to know content and then it builds up to critical thinking and test taking strategy. So there's a process to this, and I do believe this is the best way to do this. Okay, so a couple deep breaths. We're going to get into it, and I promise to not speed up, to go fast. There are some areas it's just FYI. Areas where it's just FYI, basic information. I'm just gonna go through that. But there are areas I will slow down because it's the nature of the material of the beast. So you will see me slow down. So it's gonna be a combination. And then we'll take, a break. I want you to take a breather, walk around for 5 minutes, go to the bathroom, get a snack, water, and then you come back, for at least another hour. So kind of get your psyche ready like that. Okay, so do me a favor. Let's get started, and then once we breaks, and then we'll go over some Q&A and stuff like that. Okay, so I'm looking at the time. Ready? Okay, so cardiac anomalies with the adults. Let's refresh and recap on some diagnostic tests. Got it. Perfect. Okay, so we haven't done arterial blood gases. So I break down ABGs, with metabolic acidosis, alkalosis when we do respiratory, okay? So when we do respiratory, we will break this down and I will teach you how to go about figuring out if a client is in metabolic acidosis, metabolic alkalosis, so on and so forth, okay? But for your cardiac clients, this is usually a diagnostic test that the physician will order. But the other thing too, remember, we as PNs or RNs, we don't do the arterial blood gas, the ABGs. Respiratory therapists do those. But we get test questions as if we perform this. So there are some things you need to know, like the Allen's test we'll go over when we do ABGs. And of course, the reason you're doing it, being able to break it down, even compensation. So those will go in detail over when we do respiratory. But generally what you need to know for now is that there's usually no prep for this. Okay, if they're on any type of O2, it's turned off for a little while if they can sustain that, but there's no special, NPO or staying away from certain food medication, not for that. All right, so these clients that come to the emergency room with some of these conditions we're going to talk about, there's what we call protocol, right? So protocol, we're always going to pull a metabolic panel, and we usually even pull a comprehensive metabolic panel and a chemistry panel like you see here. So let me make sure you can see my cursor. Yes. So the comprehensive metabolic panel will give you a lot more test results versus the basic. Okay, so, and generally we do want people NPO for these, but sometimes when they come to the ER, they're not always NPO. So we pull them anyway, and then we pull them again later. So with the basic, you're only going to get about 8 specific tests, like with some of the electrolytes, the glucose, but with a comprehensive, not only do you get the 8 specific tests, but you also get the LDH, you get the all the chem panels, the sodium, potassium, chloride, calcium, you get all of that. You get the ALT, the AST, so it's a lot more that you need. And again, we would like for people to be NPO, but sometimes if they're in the emergency and they didn't anticipate this happening, they usually are not, but so we repeat it later, that's all. So the chem panels protocol, okay, and of course a CBC we always pull. So those are protocol where we want to know what the HNH is doing. We want to know their platelet level, their white count level. So that's all, automatic protocol. In addition to that, if it's any type of chest pain, we sense anything like angina, MI, we're always going to pull the enzymes, the cardiac markers, okay? And with the cardiac markers, there are some that are extremely important. And there are some test questions right here. So everybody pay attention and wake up, okay? So when we pull the CK, you've heard the CK, the creatinine kinase, that is going to pull up, all the enzymes in general found in the muscle, the brain tissue, the heart tissue. Yeah, we're pulling all of that. So we can see any type of trauma. But the creatinine kinase gets broken down. So we pull also what's called the creatinine kinase MB, and that would be for cardiac muscle tissue loss that we're looking at. We can also pull the CKMM for muscle striated, and then we could pull the CKBB for brain tissue for your stroke clients. So because we're talking cardiac clients for this session, we're going to stick to the CKMB, okay? So when we pull the CKMB, if the client has had any, cardiac damage, we're going to see that it's going to be elevated. It elevates in about 4 to 6 hours after heart attacks. And it's at its peak between 12 and 20 hours. So we can tell even when the client, tissue damage, the heart attack started with the CKMB. And the greater it is, the more damage there has been. But a couple of test questions in reference to troponin. So in addition to all of that, we will also pull the troponin. The troponin is how the diagnosis happens. So there's test question where they're testing to see that how this is diagnosed. So your anginas, MIs, they're diagnosed with the troponin. And you see here a regular protein found in the striated muscle, right? That heart muscle. So troponin levels are going to elevate 48 hours after a heart attack. It is used to diagnose a heart attack. So the test question that is testing to see that how heart attacks are diagnosed, the answer is troponin, okay? It's going to even assess the degree of heart muscle damage, okay? And there are a couple. Again, the higher they are, the worse this is, okay? Right here, troponin LT. So it's that one that tells us, okay, or the physician is able to give the client that diagnosis. Every condition is diagnosed somehow. That's another concept, students, that you need to keep in mind. Every condition, every disorder, disease is diagnosed somehow. And you have to process that when you're studying. You have to ask yourself, how did they come to that conclusion, right? Is it via blood work? Was it an MRI? Was it the troponin level? You see what I'm saying? Was it the arterial blood gas? how was this diagnosed? Is it from ruling out other diseases and disorders? So everything has to be diagnosed with something. So this is the section we're going over right here. So these are the blood work and the cardiac markers. So every time you see a disorder, hear a disorder, ask yourself, how was it diagnosed? Okay, it was diagnosed somehow with something. Okay, so we're also going to pull the C-reactive protein. Those are not as, popular. So we're pulling those with these clients if we sense other things going on. So this would be, if we're looking at the liver, because this is the protein that's produced by the liver. If it rises, then that tells us there's some, liver damage. No special prep. By the way, when you're studying for these diagnostic tests, which by the way, repeat under reduction of risk potential, which is great when the material repeats because it helps stick to your long-term memory. So when you're studying diagnostic tests, here's what you want to keep in mind. Is it invasive? Is it not invasive? Are there any special prep? Do I need to stay away from certain medications or foods? Those are the things that are crossing your mind. Are there any special teaching? For example, in special assessments, like if they're allergic to something. So as we go through these diagnostic tests, I will point these things out because they're test questions. But whenever you're dealing with a diagnostic test, yeah, you want to ask yourself, are there any special preparations, special teaching? Okay, is it invasive? Is it anything invasive? You need a consent. Okay, so that's the other reason you want to ask yourself that. Is it invasive? If it's invasive, you better get a consent. If not, that's a problem. The lipid profile protocol, we're going to pull that. We need to see what your cholesterol is doing. Okay. And in your list of labs, you're memorizing your total cholesterol, your LDH, your HDH, right? So we're pulling that. They generally, yes, should be NPO. If not, we have to repeat it. Okay. The erythrocyte sedimentation, the ESR. So whenever there's inflammation, that rises. And there's no special prep, okay, for this, but there are medications that causes an increase. So that would be like a false high if they're on dextran, methyl-dopa, carbidopa, those type of drugs, oral contraceptives. That's why we must always do a medication reconciliation. Okay, theophylline, vitamin A, all of those cause an increase. What causes a decrease are family of drugs like aspirin, steroids, cortisone, quinine, those decrease ESR. So you see why we need to do a medication reconciliation, because if we do a medication reconciliation, we see the clients on these drugs, and then we see this happening with the ESR. That makes sense. It explains it. Okay. So when you get a case study, a chart, and you get a list of the drugs that the client is on, you want to process these things, right? Because remember, some case studies, you're going to get the chart and one drop down box, you click on the box, you see, okay, here are the medications the client's on. And, if they're on these and we're pulling the ESR, okay, let's say, for example, let me just make one up. The client is a female on contraceptive. So first of all, you having test taking strategies, and I tell you the client is a female, you're processing that, and they're on contraceptive, and you pull an ESR, yeah, there could be a false increase because they're on some type of contraceptive. And let's change that. Let's say they're on cortisone. You may see a decrease. So you have to put that into consideration because of the medications that they're on. History, never downplay or ignore history, okay? Liver enzymes, if I'm pulling those liver enzymes, yeah, the ALT, the AST, the LDH, then yeah, if I'm sensing, liver damage, that's gonna be part of the order that I'm pulling. Now, based on what type of blood thinner they're on, then you'll see the PT-INR pulled. So that depends on the treatment with this client if we're pulling those. A couple more diagnostic tests, so hang in there. We haven't gotten to any heavy stuff yet. So we may need to do a CT scan, okay? Computed tomography. So the CT scan is going to give me a picture, right? It's a thin X-ray that is done on certain body areas, and it's going to generate a 3D image for us to see any damage. It's not invasive, obviously. It's not painful, but there are some contraindications. And one big one is with pregnancy. So pregnant women should not do this because of the exposure. Okay, there's some exposure to radiation, even though it's a small amount, but it is still an exposure, and no one wants any level of exposure to their unborn child. So that is a concern. So please keep that in mind. And then also, if any type of we can cover though, but still, it's still an exposure. It doesn't take long. So if the physician is using a dye, you want to check for allergies, to shellfish and other products that are being used in the dye. But other than that, simple. Okay, great for fractures, those type of images. The client may need an MRI. So there are a few things with MRIs. I can think of 3-4 questions with the MRI. So listen up. And those of you who are visual learners, look at this. These brown areas right here are magnets, like magnets that pull, right? Pull metal. So that's important to know and understand. So that is why a client with any type of metal, like a pacemaker or a metal hip, knee, those type of things, they cannot do an MRI. For that reason, it's going to obscure and it could mess up their pacemaker. So that's question number one. No metals. So we even use a detector to go all over the client's body to detect any type of metal before we have them do an MRI. Okay, and with the metal, folks, we're talking even the smallest amount of metal. Those of you who have been to my recordings before, my teachings before, I've shared this example with you, and hopefully you don't forget and don't get this question wrong. We are talking even the smallest amount of metal with concerning this. So after I had my youngest child, Daniel, I had some cardiac issues, mitral valve regurgitation. I was hospitalized and I had to get an MRI done. And the young lady, who was setting me up for the MRI, she used the scanner and she scanned me, but my head kept beeping. So I had bobby pins in there. I removed them, but my head still kept beeping, and we weren't sure why that was happening. Short version of the long story, turns out, ladies, men probably cannot relate to this. The extensions that we have, they have these small little metals through them, right? So my sister does my hair, and I had these extensions in there, and the little metals are why this kept beeping. So I had to take those out before I could get the MRI. So it's so funny, I call her, to do that. And I'm like, bring me a hair cap because I'm going to be going through the hospital looking a hot mess. But can you imagine teeny, teeny, tiny little metals through the extensions, why I couldn't get the MRI? So that's question number one, no metals. Question number two, claustrophobia. There's a typo there, but claustrophobia. You see the picture. It's like you are, and not just like, you're going into a tight, closed space. So those who are claustrophobic, where they can't be in tight, closed spaces, like you being buried in a coffin, they will freak out, like I did. So they may need some type of anti-anxiolytic, or they may have to do an open MRI where it's not that in that tight space. The other thing, to warn the person, you do get a headphone to decrease, the loud sound that is within the machine. So just warn folks that, there's going to be some loud noises so that they don't freak out. So all of those are test questions concerning the MRI. Okay. With the nuclear scan, what you need to remember with the nuclear scan is that a radioactive material is always used and injected. Okay, so you want to check for allergies with this one. Okay, you see injection into the vein. And then whenever we're injecting radioactive dye, you always want to post-procedure hydrate if they can take it by mouth, but also IV. We want to get this flowing out of them, right? And we'll talk more about some teaching and contraindications with the use of the dye and the metformin. When we do reduction of risk potential is where the details of those are covered, but we would want to stop that drug. So things like that. But for this section, the allergy, okay? Radioactive, the radiographic x-ray, similar to earlier, is just an x-ray to detect heart and lung radiology, no major, no prep, nothing like that, which is great when they're simple like that, but not all of them are. Another diagnostic test, which we've already covered to death, is the EKG, okay, over here. So this one we're done with. So let's cover this one, the cardiac catheterization. So I mentioned a little bit last time under the pediatric section where it is contraindicated for the pediatric client to ever do a cardiac catheterization whenever there's a diaper rash. And you remember why? It's because of the fungal infection. We never want to introduce, right, a fungal infection, any type of infection or bacteria or pathogen into the bloodstream. Because look, we usually go via the groin. And if there's a rash there, too great of a risk of introducing that pathogen into the bloodstream. Okay, so a dye is injected through the catheter via the groin or the arm. The groin is the most common place. Okay, and it makes its way through the coronary artery, and we're able to visualize and see that. They should definitely be NPO for this one. And anesthetics are used because, yeah, that's a large bore needle catheter puncturing. So you'll feel that. The client will feel that, okay? There is a lot of test questions post a cardiac catheterization, after. Okay, so after they come out with a compression bandage, that's pushing to stop the bleeding, any bleeding or hemorrhaging, it is imperative that the client be on bed rest for at least, 6 to 12 hours. You don't want them flexing the hip, okay? Because if they flex the hip, that's risk of bleeding and hemorrhaging. You want to check pulse below the insertion site, okay? So popliteal, if you don't feel a pulse below, then that's a problem. They could be hemorrhaging. So I'll talk a little bit more in detail about this one. We did EKGs already. You know about the 3 distinct waves. You know about the abnormal rhythms. This one was fun. So we've covered that one already. Just a couple more. So sometimes we may do an echocardiogram. Okay, that's going to tell us any type of heart failure, great for monitoring that. And it's, painless, but the client needs to be able to follow directions, maybe change position, that type of thing. But other than that, no special anything. Okay, they don't need to stop any medications, NPO, nothing like that. If the physician uses a dye, then yes, EKG, allergies, but really no special anything. So sometimes we may do this while stressing the heart, okay? So that would be a exercise cardiac stress test. So it's really the same thing where we're visualizing the heart, taking pictures like an echocardiogram, but while stressing the heart. And these are great. We're able to tell ejection fraction. Remember we talked about that, how much blood is leaving the ventricles every time the heart contracts. Okay, so while the client is on the treadmill, okay, we can measure the entire heart, the blood vessels, how much blood is leaving the chambers. Great. Now, you're never leaving that client. During an exercise cardiac stress test, can you imagine, God forbid, right? They become exhausted and fall right on the treadmill. So you don't leave this client. You're staying with this client, okay? The radionucleotide stress test, so that uses radioactive isotopes. So you're going to check for allergies. So this one is going to take images and is looking for cold spots like you see in the picture here, right here, right here, right here. So any type of blockage in the coronary arteries is going to cause decreased blood flow, obviously, and it's going to show up like these cold spots you see here, okay? One last one called the Muga scan. Now, This one, I remember I was doing a live NCLEX review, and it must have been maybe about 30, 35 students in that class, give or take. And some of them had already taken the test, and about 3 of those students had this test on their NCLEX, and they had no idea what a MUGA scan was. So I know for sure this is floating on your NCLEX from what students are saying. So what is the purpose of the MUGA? It has a unique name, and that's why they didn't forget it, because of the uniqueness of its name. So MUGA, okay, multi-gated acquisition. So it's scanning the heart, and what it's doing is it's looking at the chambers of the heart. So this also will tell you ejection fraction. Every time the heart contracts, we want at least 60, right? 60%, the greater the better, of blood leaving the chambers and going to its destination, right? It looks like an open MRI, nothing, different than that. But you see here, it's looking at the chambers of the heart, and it could also see the valves to make sure that there's no valve damages, concerning the heart, which is great. No special prep. If a dye is used, check allergies. So they're attached to an EKG while this is being done. So that's a MUGA scan. So if you see that on the NCLEX, they're either testing to see that its purpose, ejection fraction, and the valves. Other than that, I can't think of another question that would be affiliated with that. Okay, so let's try a simple question so you can kind of see the style of questions that will generate from this type of material that we just covered. Okay, so here's an example. A client is diagnosed with hypochondria, states an allergy to the dyes used in diagnostic tests, and all radioisotopes. You're processing that all word. It's an absolute. The nurse explains that the client could undergo which diagnostic procedure without risk of possible allergic reaction. So if I'm going to rephrase the stem of this question, okay, which is the stem of the question is the part of the question that asks the question, so answer the question. They're just testing to see that you know which test here does not require the use of radioisotopes. Is it the MRI? Is it the myelogram? Is it the ventilation perfusion VP scan, or is it the CT scan with contrast? I know you're throwing that one out right away because it says with contrast. Okay, so you should be between 1, 2, and 3, because 4 you eliminate right away, process of elimination. Okay, really you should be between 1 and 2 because the perfusion scan, yeah, uses those. So let's go over that. The answer is the MRI, okay? And let's go over why. This is the remediation part. This is what you need to do with every question. So the MRI is the only diagnostic examination listed that does not possibly require the ingestion or administration of a contrast or radioactive material where we need to check allergies. Okay, 2 and 4 involve the use of contrast dye or agent, while option 3 uses radioisotope. So really, they're testing to see that you know which diagnostic tests require the use of a dye or contrast and which ones do not. So when you're studying, you're thinking like that. Okay, and you're thinking which ones are invasive, not invasive, NPO, not NPO, special teaching. Okay, let's try another one. The nurse has admitted a client to the emergency room with complaints of chest pain over the past 2 hours. There are no clear changes on the 12-lead ECG. The nurse would expect which laboratory test to provide confirmation of a myocardial infarction in MI. So how do you diagnose an MI? That's it. You see how I rephrase questions? That's really all this question is asking you. How do we diagnose this? We don't diagnose it with the potassium level. We don't diagnose it with WBC. So you should be able to eliminate 1 and 4. So 2 and 3 are really telling you the same thing, but one of them is worse and would be a better confirmation of for sure, not only for sure cardiac tissue, but greater cardiac tissue. Okay, CK, same thing. And if you didn't know that, once you're above 150 and they're both above 150, and this one is 4%, whereas we have 12%. Great question. So your answer is 3, CK of 320 with MB of 12%. So anything above 150, you're there. Over 5%, that means a lot of myocardial damage from that MI. And the potassium in the WBC is not used to diagnose MI. So in addition to that, the troponin, okay, which I've talked about earlier. So those give you an example of how you would see these questions phrased, okay? So we're going to get into some disorders and then you can take a breather. All right, so our first major disorder is the coronary artery disease. Very important. So the routine is going to be to define the disorder, go over the pathophysiological process as to what's happening. That's important for you to understand. Patho is big. So we'll always go over patho, what's happening pathophysiologically. And then we'll go over, potential causes, risk factors, those type of things. We'll go over how do we diagnose this, right? What is used to come up with the fact that the client has coronary artery disease. So we'll do that for each disorder, and then we'll go into management. And then we'll go into nursing interventions, right? So and you're going to see me follow that protocol for every disorder. And you want to think like that too, especially when you get these case studies, okay? So that's gonna be the routine. I like order. It just helps you organize the material. So coronary artery disease, what's happening here? Okay, so remember when we did the anatomy of the heart and I showed you the coronary arteries covering the heart. Let me show you real quick again. So those of you who don't remember, look at right here. These are the coronary arteries branching from the aorta, okay? So they are blocked. Fatty deposits, clots, could be a number of reasons, but there is a blockage. Usually it's fatty deposits that lingers there, and it's often it's due to the LDL being too high, the lousy cholesterol. Okay, that's why we want that to always remain low. Okay, because it attaches to the wall and it blocks and blocks, accumulates, and then decrease blood flow. It narrows the artery. Okay, imagine 75% or greater. That's not a lot of space left for blood to flow. And whenever we have decreased blood flow, whatever's at the end of that receiving end will die. And that's muscle, heart muscle, terrible, okay? So most common cause is arteriosclerosis due to elevated LDL. What are some of the risk factors? Please, 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 when you're studying, pay attention to risk factors. There are risk factor questions where literally, okay, they're asking you, they're giving you clients and they're asking you either how many, who has the most risk factor, or they'll give you the condition and say who's most at risk. So these can come in different ways. Okay, so you may want to, you need to pay attention to risk factors when you're studying. So for coronary artery disease, there's a little culture tag attached to that. If you watch the test taking strategies recording, I go over this test taking strategy. There are conditions that are culture sensitive. That's just the way it is. So for coronary artery disease, it's male, Caucasian males over 40. Of course, family history, right? Your history puts you at risk. Hypertension, high cholesterol, especially with your LDH. Okay, I'm sorry, LDL. Obviously, smoking, you already knew that, okay? Doubles your risk to this, okay? And the risk drops sharply within 1 year after cessation, so it's great when folks stop within a year, their risk factors, which is great. Obesity, especially what we call visceral fat. Visceral fat is fat around the stomach. Okay, that puts people at risk. If you're overweight, it's best to carry your weight in your legs and buttocks, even your chest. It's dangerous to carry your weight around your stomach. That's called visceral fat. That increases the risk. Okay. Diabetes, you knew that one. Okay, hypertension, high cholesterol, and a lifestyle that doesn't include exercise. That's what we mean by sedentary, okay, or sedentary lifestyle. That is a lifestyle without exercise. Okay, so all of those put you at risk. Now you can see this as a select all that apply. You can, right? You can imagine that as a SATA. Okay, and here's something else they do too that I've been seeing, because I practice a lot of case studies because of Next Gen. Remember, this is my job. And another nice question I see that they do often is testing to see that non-modifiable and modifiable risk factors. So let's go over that real quick. Non-modifiable meaning you cannot change it. You're born into it, okay? Or it's just something you cannot change. Modifiable is something you can change, okay? So you can change your diet, you can change your level of exercise, right? You can lower your cholesterol, right? With lifestyle changes and measures. You cannot change your familial history. You cannot change your cultural background, right? You see, those are non-modifiable. You can't change aging, getting old. You just can't change these things. So those would be non-modifiable, non-changeable. Modifiable, changeable, you can do something about it, okay? So know that. So those are usually, by the way, like level step 2 in your clinical judgment model to show that you can link, right, information. So be aware of that. All right. So one of the findings is that wonderful, awesome, I'm being sarcastic, horrible chest pain, right? That radiates. I have a nice picture of that to show you in a moment. So that's one of the findings they present, right? Saying, you know, my chest hurting. There's an elephant on my chest. We're going to get to MI in a moment. How do we diagnose this, right? So we're going to pull the serum levels, right? Homocysteine levels with the blood. We're going to pull the protein, the cholesterol. The physician may do a cardiac catheterization, and we'll be able to visualize this and see it and maybe, you know, treat it as well. So you're going to see those diagnostic tests. Management. There are several forms of management. For the chest pain, the angina, you know, we want to give nitroglycerin. We will talk about nitroglycerin to death in a moment. Okay, there's lots to know about this drug, lots of test questions. Okay, and then how to administer it, you know, the 5-minute wait. We're going to talk about that in a moment. So nitrates such as nitroglycerin, isosorbids, isordil is part of the regimen. The beta adrenergics we'll talk about. In addition to diuretics and the beta blockers, those are for the hypertension. The antiplatelets are part of the regimen, that 81 milligram aspirin forever, because we want to reduce platelet aggregate and decrease platelet, you know, aggregation. That's part of the regimen. Of course, we need to lower their cholesterol. So the antilipids are part of that. We'll talk about those drugs and little craziness you need to know for each drug family. Put them on oxygen because they're going to be hypoxic. Okay, so they'll have O2 on. Okay, and there's some lifestyle changes. Okay, so moving forward, they need to be on a low calorie, low salt, low fat, low cholesterol diet. Yes, we'll talk about cardiac cath in a moment. Another treatment is something we call rotational ablation. That's this right here, and you see it, when you see it makes sense. Rotational ablation. So it's going to be like, right, to get rid of all that excess plaque. So that's rotational ablation. Okay, we could get a coronary angioplasty done. We could get a stent. This is a nice picture of a stent right here. You see how there's so many treatments, right? Of course, we want to go from least to most because we're like that. Worst case scenario, they may need major surgery, right? Which is a CABG, a cardiovascular bypass graft surgery, which is this procedure in the bottom, on the bottom right here, where we take a blood vessel from either your arm or your lower extremity, and hence the name, we're bypassing. So the area that's dead, we're gonna bypass it by connecting the artery from wherever, from another part of your body, and connecting it to the section with the dead tissue. So it's a bypass, okay, hence the name. So short CABG, okay, you've heard us say CABG. So now that's management, obviously a lot of management, and everyone please be familiar, like know how to treat these conditions, because that's clinical judgment. That's the next generation stuff I'm teaching right now, where at one level, they want to know that you know proper treatment. And what makes this difficult is that not only they want to know that you know how to treat, they also want to see that you know contraindications. So those are the type of questions where they'll put these different measures where you have to say indicated, not indicated, contraindicated, not necessary, you know, like you have to X, X, X. I'll show you an example when we do the case studies, but you have to think and study like that, okay? So now nursing intervention. Remember, I told you there are some clients you do not stress the heart. That's one of them. Do not stress this client's heart. You're gonna see again and again and again, I'm going to say, decrease the workload of the heart, decrease the workload of the heart, decrease the workload of the heart. So please don't miss these questions. So how do we not increase the workload of the heart? And how do we decrease the workload of the heart? Any little thing we do, the heart is a part of it, and we exhaust the heart. We overexert it, which is not a good idea for these clients. So we, the nurse, everybody is going to be helping this client with their activities of daily living. We don't want them doing things that are gonna cause them, you know, to be in this state. So the commode right by the bed, even eating sometimes exhausts clients. Okay, they're on bed rest. Okay, we assist them with turning, deep breathing, coughing. They have an oxygen. We give them their medications on time. Okay, we don't want to overexert the heart. So during their angina attacks, we're monitoring their blood pressure. You kind of already know this stuff. We're monitoring their heart rate, their pain level. Pain exhausts the heart. You're gonna see in a moment. They're always on an ECG, okay, on an EKG, always. And the nitroglycerin is right there, right there, okay? Immediate, yeah, availability. Okay, so those are some of the nursing interventions. Keep those in mind, okay? Now, let's talk in detail about the cardiac catheterization. Now, you see, I love teaching the way I teach because I've mentioned this several times, right? So you're so familiar with it now, but now I'm gonna dive into some detail, and this is a beautiful picture right here of what you need to visualize with a cardiac catheterization. So remember, we go via the groin, most common area, large bore needle, and we're puncturing and filtering all the way to the coronary artery. Okay, so much we can do with this test. So post, there's a lot of questions after this procedure. So post a cardiac catheterization, sometimes you'll see percutaneous transluminal coronary angioplasty, same thing. So of course we want to always heparinize, right? Because if not, you're pushing a clot. So we maintain heparinization. So heparin you saw earlier, right here, we are always with this procedure. So we are observing for bleeding, obviously, okay? That's priority. So that area, we don't want that leg bending, kinking, or flexing, okay? So that leg needs to stay straight for at least 6 to 12 hours. So they can't go to the bathroom, put a Foley catheter if need. Okay, no kinking the hip, no flexing, they can't. Mrs. Jones, lie straight for me for the next 6 to 12 hours, do not move. If they need to pee, you gotta put a Foley without bending. Check for distal pulses, yes. distal pulses, because if you don't feel a pulse, then there's hemorrhaging right here if you don't feel a pulse, below. If there was any dye used, same message earlier, they're gonna be an IV fluid to flush that out. They're gonna be an oral fluid if they're able to. We wanna pull their potassium level. We want to always continue to monitor, so there'll be an ECG, okay, and an EKG. So I'm doing the vitals. I don't want them going hypotensive on me. I don't want bradycardic, okay? Are they sweating? Are they dizzy? Okay, if I have all this Brady stuff, we already talked about atropine, and keep them flat. Okay, and similar thing with the rotational ablation. We don't ever want chest pain, hypotension, any spasms, coronary artery spasms, or bleeding from the site. This is a nice new device, with that applies the pressure, and then we can access if we need to, and then we can blow up this little balloon there to put the pressure. I love seeing inventions like this. I love it. Whoever came up with this, kudos to them. Awesome. Okay, heparin antibiotics for the first, 1 to 2 days post. So those are your post nursing interventions, teaching for these clients. Break soon, but hang in there. The pain, okay, the angina. So it's the type of temporary chest pain that puts so much pressure on the client to where it kind of takes their breath away. And that's because there's a narrowing, okay, a blockage, a decrease, right, with the pathway in the coronary arteries. Now, if that continues, you end up with ischemia, dead tissue. Okay, because that section of the heart is not receiving blood, and no blood, no oxygen, because of that narrowing. Obviously very painful. The client says, there's an elephant on my chest, it radiates, and we're not talking a little bit of pain here. This is severe, pain for these clients. So when we're using the word angina pectoris, we're talking about that severe pain. Now, how do we address that? How do we treat that? There's several questions concerning this. Okay, so now when we're talking angina pectoris, we're talking partial occlusion. Okay, so it is time to give that nitroglycerin. So nitroglycerin comes in a tablet, sublingual, under the tongue. It comes in a spray, right? We have patches. We have so many forms of this. So test questions in reference to the sublingual and the spray. How do you administer this, right? So let's imagine the client is at home. Okay, so the teaching, for the family and friends, the caretaker, whoever it is, the client themselves, is to do 1 sublingual tablet under the tongue. Don't swallow it, because then it won't be sublingual after that. So under the tongue, and wait 5 minutes, right? If that pain is still there, then you would give dose number 2 and wait another 5 minutes. Right? If the pain is still there, then you would give dose number 3, right? And then wait 5 minutes. That's the 15-minute that we're talking about here, up to 15 minutes duration. Now, if the client still has pain after 15 minutes, it is not an angina, it's not a partial occlusion. They are in a full myocardial infarction, meaning no blood flowing. Okay, they need to be in the emergency room. Yes, you would call 911, stay on the phone with them, and ambulance needs to come get them. You don't tell the family members to drive them. Okay, a few more with this. So let's recap, and then we take a breather and then continue. So let me show you a picture real quick. So with an angina, we're talking partial occlusion, not this. This is full occlusion. This is a full MI client, which is our next conversation, okay? But for an angina where we need to initiate the nitroglycerin, it's because we believe it's partial occlusion. But if after 3 doses, waiting 5 minutes with each dose, and the client is still in pain, that is not a partial, it is a full-blown MI. If, in the question, the client is at home calling you with this, you're directing the family member, you need to call 911 while they're still on the phone to come get this client. The client needs to be in the emergency room with proper care at that moment, okay? Okay, so we have covered quite a bit so far. Go ahead and take a quick break, okay? Nothing extensive, and then we will resume. All right, time to resume. So we are going to resume with MI, full-blown myocardial infarction. So we are not talking about a partial occlusion with this. We are talking about a full 100% like you see here in this picture right here. That's a full occlusion, okay? Imagine no blood going through to the other side at all. So here's the definition: insufficient, not enough, oxygenated blood, okay? Without oxygen, death, okay? So here, that's why you see the word kills here, which causes necrosis, which is dead tissue. And this is important tissue, myocardial tissue. So obviously that's why these clients are priority. Literally, you walk into the emergency room, you say you have chest pain, everybody else to the back, your priority. So don't ever fake that when you go to the ER, right? Because you walk into the emergency room, you see like it's like a Walmart running out of toilet paper. So you fake a chest pain. Yeah, don't do that. But you would be made priority, and you should be made priority, because this is, yeah, death is coming after that, not long after either. So myocardial tissue is dying. It could be sudden, it could be gradual. Okay, it takes about 3 to 6 hours. So this client would be a priority. Okay, now here's some statistics you need to keep in mind, some epidemiology you need to keep in mind. This is equal for men to women. Okay, so it's not worse in men or, you know, worse in women, but we do want to look at those risk factors that we talked about earlier with a coronary artery disease. So same thing earlier, the same risk factors for coronary artery disease is the same for an MI, because the coronary artery disease is going to lead to this, okay? So smoking, obesity, cholesterol, all that we talked about earlier, and, you know, even stress. So that's why we need to find ways to relax, control our thoughts, control what you can, and leave the rest up to God. Of those who survive an MI and recover, up to 10% die within the first year. So that's how serious this is. That's how serious to prevent this from ever even happening, because you decrease your lifespan. Okay, so this is serious conditions. So how do these clients present, right? Similar to the coronary artery disease, the angina client. So they say there is persistent, meaning non-stopping. So it's not like they get a relief from this pain. It is persistent. It doesn't stop. Okay, crushing substernal chest pain, and it radiates to the left arm, jaw, neck, you know, the whole left side. They feel like, you know, like the life is leaving them. That's the whole impending doom feeling. Okay, and nothing gets rid of this pain. Now you see this stuff in red on the bottom. Let me read that. That's how important that is. And you know, I don't read to you, right? I teach, but I'm going to read these sentences for a reason. I want you to remember this, okay? Some clients report no pain or call it a mild indigestion, like a little heartburn. And those two clients are your elderly and your diabetics. Now, I cannot stress to you how dangerous that is. They are having a heart attack, but they think they're having heartburn because they don't feel it like you and I would. That's called a silent killer. By the time they seek help, it's too late. It would have been better for them to have felt this thing at its 100%, but they don't. And they think, oh, I'm having a little heartburn, a little indigestion, and it's a flipping heart attack. So very, very dangerous. That's a silent killer. So remember those two clients: your elderly, decreased sensation; your diabetics, decreased sensation. Okay. So yeah, we want to watch them. Any little sign of, you know, fatigue, change in mental status, you know, we want to take it seriously in those clients, because it could be something like this. Okay. And you can visualize this. This is a nice visual. All that blue is dead tissue. Okay. All right. How do we diagnose this? We've already talked about the CKMB. So in addition to that, don't forget the troponin, right? We're going to use those to diagnose this condition, okay? Yeah, so management, you're always putting oxygen on these folks, like without say. That's one of the first things we do. Put that oxygen, put that pulse ox. We're monitoring BP, heart rate, and O2 sat, like automatic, okay? We want to prevent that hypoxia because that's what's happening. This is hypoxia, okay? So let's prevent it, put oxygen on them, okay? So as this gets, more and more serious, there may be an induced hypothermia, right? Induced, like we're causing it. So that's for severe cases. Now, let's talk about the pharmacological, right? Medications. Okay, so our goal is we want to stabilize this client and we don't want to stress their heart. Okay, we don't want to stress the heart. You're going to see, I'm going to sound like a broken record because it is what it is. So the regimen, the pharmacological regimen is going to include stool softeners, narcotics, beta blockers, sedative, antiarrhythmics, thrombolytics, nitrates, anticoagulants. So let's start over again. Why the stool softeners? To decrease the workload of the heart. We don't want this client constipated. If God forbid they become constipated, they're straining. You Valsalva when you're constipated, you bear down and that stresses the heart. So this has to be part of the regimen. Okay. If they end up, causing all that excess vagal stimulation, which we talked about before, that could produce some bradycardias and some arrhythmias. So let's avoid it. Stool softeners, part of the regimen. Narcotic analgesics, we don't want them in pain. We want to reduce pain, anxiety, and fear. Why? To decrease the workload of the heart. So they're going to be on painkillers. Beta blocking agents. We want to slow that heart rate, decrease the contractibility of the heart. Why? To decrease the workload of the heart. Sedatives, we want to decrease that anxiety and fear. Why? To decrease the workload of the heart. You kind of get the point. Okay, so the antiarrhythmics are for the dysrhythmias, okay, depending on which one their symptoms. The thrombolytic agent, okay, we want to dissolve any thrombus, okay? We want to dissolve it. We don't want it traveling. If it's going to travel, we want it where it's not blocking anything. So that's what, don't mix, by the way, don't mix thrombolytics with anticoagulants. Very different. We'll talk about them a little bit later. Thrombolytics are clot busters, like TPAs, and anticoagulants are clot preventers. Okay, you see they're also on those as well. So if they have a current clot, we're going to use thrombolytics. To thin the blood to prevent future clots, we're going to use anticoagulants. Okay, nitrates to decrease the pain, then decrease the preload and afterload while helping the heart work better and getting more oxygen. So this is the regimen. This is the pharmacological. Okay, in addition to that, you'll see the client on something we call the Swan-Ganz. Okay, so this is the pulmonary artery catheter. So it literally filters all the way to the pulmonary artery. It's called the Swan-Ganz. Okay, it's going to monitor pressure in the pulmonary artery of the client. It's in the left ventricles of the heart, if you can imagine that. Or sometimes you'll see a intra-aortic balloon that's done surgically. So we're gonna monitor any cardiogenic shock, right, and prevent that stuff. Cardiac catheterization, we've already talked about. So lots of, management and treatment for these. And if the client, the sicker they are, the more of that you'll see. So that's management. Now let's talk about nursing intervention. Okay, so you see how we did patho, we did causes, risk factors, how the client presents. And so we're in our order, in our routine. So nursing intervention, there's quite a bit we need to do for these clients. They're really sick. Okay. So there's a little thing we call the Cardio Care 6+ monitor. So obviously they're in the regular stuff, right? We're monitoring the blood pressure, the heart rate, the pulse ox, all of that. In addition to that, the daily weight, the INO, the respiratory rate, breath sounds, the Kim panels, the enzymes, they're on an EKG. So all of that, is in addition to what we would do for a regular med-surg client. We don't want these clients in pain, never, right? Because that stresses the heart. Now, here's a nice test question that sometimes I see students forget. In these clients, we avoid IM injections, intramuscular injections, because, or at least we don't do it until after we obtain our CK levels, right? Because when you do IM injections, you're messing with muscle, you're breaking down muscle, and we're going to get a false elevated CK. So usually we'll pull our CK before we do IM injections, okay? We're monitoring the lungs, okay, for crackles, cough, any type of tachypnea, edema, their respiratory status, because this client could go into a left ventricular failure mode. So we want to monitor them. And we're going to talk about right versus left-sided heart failure. One could lead to the other, to full-blown heart failure, okay? And they are always on an anti-embolism stocking, or the TED hose, the compression boots, okay? We want to prevent vasostasis or thrombophlebitis. We want to prevent these, okay? Range of motion exercises, lots of teaching. We talked about the diet change. That's just the way it is. They'll have to, okay? And they're usually in rehab, these clients. Those are long-term. You want to teach them about resuming sexual activities. Remember, they have to be able to go up at least 2 flights of stairs in order to do that. We want to teach them about taking their nitroglycerin before sexual activities. And so we want to prevent that chest pain that could come because of that. Okay, and they have to report any type of typical or atypical chest pain. Like, the earlier the better. The sooner we catch these things, the better. Okay, and there's some post myocardial infarction syndrome we want to teach them about. And call your physician. And these clients should be around people all the time. Okay, and there's a lot of life changes, behaviors, modification that has to happen. They can't continue to live the way they used to live, especially if we're talking about things like, continuing to smoke and eating the wrong type of food. They're just going to get worse and worse. So lots and lots of teaching, okay, with these clients. You imagine that. So there's some little mnemonics or tables like this one, that you want to go over. Let me show you what you're pulling out of these when you go over them again. So I've mentioned the activities of daily living. So these are the clients that you are doing and helping them with their ADLs, their activities of daily living, because you don't want to stress the heart. You know the why, and it makes sense, people. You don't realize how much you work your heart because you're healthy. But people who aren't, any little thing, right? And they go backwards instead of forward. So keep that in mind. There's silly questions, right? With stuff like this. And this is the select all that applies again, because it's just, if select all that applies, require you to know the material really well and to require you to know detail. That's why what we do on Saturdays, right, on live sessions on these teaching are great, because we go over the detail. The other recordings, webinars have those too, because I believe in teaching like that and preparing you. I rather over prepare you, if anything. Bed rest. Okay, reduce the oxygen demand of the heart so you can reduce the workload of the heart. I mentioned the commode, it needs to be right there. The less travel the client does, the better. You decrease the workload of the heart. Diversion, don't stress this client. Even I've had clients, even if family members are aggravating them, I ask people to leave. I'm so sorry, you're stressing my client. Get out. Okay. Elevate the head of the bed. Semi-fowlers are great. Sit up, great way to breathe too. Expand the chest, improve oxygen, going in. Okay. And we always want to decrease concerns because that stresses client. You see how we're even decreasing anxiety, right? To decrease the workload of the heart, because all of that stresses the client. Even positive thinking, I teach people. Think positively, stop worrying. What are you gonna do? Do the best you can and move on. Control your thoughts. All right, a few more. So there are tests and treatments. We want to explain those to clients. We talked about them. They're going to be on medications that we need to teach them about, explain to them why they're taking it, the purpose. They have to change their diet and their lifestyle. They must be moving forward, be on a low sodium, right? Low cholesterol. And if you haven't watched the nutrition teaching, yes, proper dieting is great. Teaching client to remove the skin off of meat, to bake instead of fry, like silly little things like that. Okay. Their treatment, smoking, yeah, they need to stop smoking, and that's not as easy as it sounds. Sometimes it's very difficult for people to do. Okay, so these are little things you need to keep in mind. Okay, we need to start talking about drugs, pharmacological. All right, so let's get into these medication treatment for these conditions, okay? So I mentioned already that they will be on an anticoagulant, anti against coagulant clotting, right? Those are your heparins and your warfarin, Coumadin, okay? So heparin, note that is sub-Q and IV, right? Two routes. But warfarin and Coumadin are the same, brand name and generic name, orally. Okay, we're gonna break these drugs down. So let's go over the mechanism of how they work. Do not underestimate this. You need to know the mechanism of how drugs work. What is it that they're doing and how are they doing it? Because you have drugs that does the same thing, but in a different way. And that's what's happening here. Okay, these are both anticoagulants. They're under the same family. The anticoagulation is the drug class. Okay, but so imagine them as cousins. If you want to think of it that way. The heparin family is given sub-Q and IV, and the warfarin family is given orally only. All right, so heparin, but they both do the same thing. Heparin, they're gonna prevent thrombing from converting to fibrinogen to fibrin. That's how they thin the blood. Warfarin stops, literally suppresses coagulation, and that's how they thin the blood. And how does it suppress coagulation? Because it is an enemy of, it is an antagonist of vitamin K. Okay, but it takes forever to work. Well, to get to a therapeutic range. Okay, some books will say 3 to 4 days, some books will say 4 to 5 days, but yeah, that means this client is going to be hospitalized minimally, right? For like 6 to 7 days minimally. Okay, so we give these. What are the indication? Why do we give them? If there's a thrombus, if there's any type of pulmonary embolism, MI that we're talking about. Adverse effect, it doesn't matter which one. Whenever you're dealing with adverse effect, you're thinking the whole family. So it doesn't matter if it's heparin, warfarin, bleeding. If it's an anticoagulant or thrombolytic, bleeding. Okay. We don't aspirate when we're giving heparin because it's sub-Q. We also teach the client, don't rub the area, don't hit pressure around the area because they're gonna bruise. I'll show you a picture in a moment. Now, that happens, okay? So you have to teach the client, yeah, don't put pressure, rub that area because of that. Now, there are some therapeutic levels that you need to memorize. You already know that, and I'm going to go over those with you in a moment. You also need to know the antidote to these. Whenever there's antidotes, I'm going to mention them, okay? You're going to make a list of antidotes. I can just send you one too, and within the course so that you can work on these, okay? So for heparin, the antidote is protamine sulfate. You have to commit that to memory, okay? We'll go over some memorizations of levels in a moment, right here, this little table. So instead of doing that math with 2 to 3 times, you know, the normal level, you just want to memorize these. So the normal lab level for PT that we want is between 11 and 13 seconds. That's with the blood thinning. literally we're looking at it for 11 to 13 seconds is the therapeutic range that we want, but a therapeutic lab value when the client is on the drug, we want between 15.5 to 35 seconds. Now, this does vary a little bit in your test questions, or from book to book, rather. So just memorize this one. When you get the question, it's extremely abnormal. So you don't need to worry about if you see 15 in a book versus 37 in a book or something like that. Okay. So memorize that. Okay. The therapeutic lab range. And for somebody who's on Coumadin warfarin, if they're on the drug, we want that therapeutic range between 2 to 3. Okay. For the APTT, we want that therapeutic range between 45 to 100 seconds. Okay. So PT, 15 to 35, APTT, 45 to 100, INR, 2 to 3. Okay. You're committing those to memory. Not much I can do about that. Okay. We still have a few more drugs. So with the anticoagulants, that's oral Coumadin, okay, Coumadin warfarin. So you know how they work. You know their interaction, okay? It's going to interfere with vitamin K, as I mentioned earlier, dependent clotting in the liver, okay, which causes prolonged bleeding. That's how they thin the blood, okay? As I mentioned earlier, Coumadin warfarin takes days to work. So that is why, like in MI client, you'll see them on both Coumadin and warfarin. I'm sorry, Coumadin warfarin and heparin, because the heparin is going to work right away, whereas the Coumadin warfarin is going to take days, and then you'll see them wean off of the heparin, okay? Because this won't start working right away, okay? So it's going to be titrated to be in the therapeutic range based on the PT-INR. Okay, so when a client is on warfarin Coumadin, we are only looking at the INR PT to adjust it. The APTT wouldn't help. The APTT is for heparin. Let me repeat that. So pay attention to that question. Don't mix what I'm saying. Let's start with heparin. When a client is on heparin, we're looking at the APTT. Let's go back. We're looking at right here, 45 to 100 for the therapeutic range. That's if they're on heparin. If they're on Coumadin warfarin, we're looking at these two. We're looking at the PT, 15 to 35 seconds, and the INR, 2 to 3. Okay? So don't mix that in your test questions. Pay attention, what drug is it? If it's Coumadin warfarin, I care about the INR PT. If it's heparin, I care about the APTT. Okay, so we use those for MI that we're talking about. AFib we've already talked about. Atrial flutter we've already talked about. If a client had mechanical valves, so a number of reasons why we may need to use these in order to prevent clot, DVT obviously, pulmonary embolism obviously, and bleeding is an issue. I mentioned that earlier, okay? So bleeding, skin necrosis, bone marrow depression, liver dysfunction. So if they already have a history of liver, then we need to reconsider. Whenever a client is on an anticoagulant, it doesn't matter which one, they are on fall precaution. Okay, put them at risk for fall, bed low, note at the side, put everything next to them so they don't try and reach and fall for it. All these little measures, they're on fall precaution. Okay, and if they're at risk for fall, that's a risk, because if God forbid they do fall, they'll bleed internally and could potentially die. That's a big deal. Okay, if there's malabsorption syndrome, this is orally, that's a problem. Severe hepatic and renal, the liver is going to break it down. And if the liver is severely impaired, how is it going to get broken down? It's not going to happen. If they have renal impairment, whether acute or chronic, how is it going to get out? It can't. If they already have a bleeding disorder, active bleeding, that's a problem. Invasive procedure with the bleeding to the spinal cord, that's a problem. So these are contraindications. Okay, risk for fall clients, clients who can't absorb it because it's orally, clients with liver, that's how it gets broken down, clients with renal, that's how it gets excreted. They're already bleeding, it's going to cause them to bleed, and they've had recent invasive procedures. So these are not clients who should be on anticoagulants. That just complicates everything. Okay. So now, okay, the regular heparin that we're talking about, let me go back real quick. Your, high molecular heparin that's given sub-Q and IV is very different from your unfractionated heparins. Okay. Versus your low molecular heparin. So imagine this. So there's two subcategories. That's a good way to think about this. So you have your unfractionated heparin, which is heparin, right? Sub-Q IV versus, so I'm going to come back, don't worry, versus your low molecular heparin. So two umbrellas. So you can think of it as high and low, right? But the proper terminology is unfractionated, okay, or low molecular, high molecular heparin versus the other one, low molecular heparin. They're different. Why are they different? And what do you need to know about them not to mix them, okay? So the regular heparin that the client will be on, when they get hospitalized to thin the blood and prevent future clots, is what we're more familiar with. I'll talk about the others in a moment, is your heparin sodium injection, right? See, IV or sub-Q. This is unfractionated because it's a little bit high maintenance too, because we do need to monitor the APTT with this. It could cause the client to bleed to death. Okay, so for the unfractionated heparin, it's going to inhibit prothrombin and thrombin, preventing fibrin, like we talked about earlier. That's your heparin sodium. You know why we would need them: MIs, AFibs, same reasons earlier. The big difference between unfractionated and low molecular is the APTT. You will always pull the APTT with your heparin sodium. Now I'm going to come right back. For your low moleculars, which you're familiar with as well, your dalteparin, Fragmin, or your enoxaparin, Lovenox, okay, most patients who aren't mobile at the hospital on Lovenox. Those are low molecular and do not require you to monitor the PT, INR, APTT, none. Very low maintenance. Okay, we just want to teach the client to not rub the area, those type of things. So let me cover this while I'm here. So low molecular heparins, your enoxaparin, your dalteparins, please work on generic names, not brand names, but you probably are more familiar with the brand names. You have to undo that. Okay, moving forward, you're studying generic names. Okay, so be familiar with enoxaparin, dalteparin. That's your new vocabulary. They're gonna block certain factors, factor A to A, without causing the blood to be so thin to where the client bleeds out. They don't affect thrombin or prothrombin. That's why you don't need PT. That's a test question. Don't think I'm spending time on there because I feel like it. No, I see students miss this test question all the time. And I'm like, you're missing content. Nobody taught this to you. So low molecular, enoxaparin, dalteparin, no PTINR, no APTT. Okay, and we use those prophylactically. Okay, it's prophylactic. We want to prevent you from ever, right, having a thrombolytic disorder. Okay, so anybody who's not mobile should be on those, should be on those, like it's prophylactic. Okay, adverse effect, bleeding, thrombocytopenia, angioedema, not very high with these, but it is a risk. Okay, dyspnea, rash. So please, 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 don't mix these. If they already have bleeding disorders, yeah, not for them. Active bleeding, not for them. If they already have thrombocytopenia, the low platelets, not for them. Their blood pressure is not under control, not for them. There are some contraindications. Okay. All right. Now let's go back to our regular heparin that we used to. So just recap, you're familiar with heparin sodium. We use them for a number of reasons. They're under this umbrella because we're talking about anginas and MI, right? We would use them for those stroke clients, DVTs, pulmonary embolism, atrial fibrillation and flutters, which we talked about before, DICs. Okay, so adverse effect, obviously hemorrhaging, bleeding, but also if the client is a smoker, we need to keep that into consideration. Okay, nitroglycerin, that's a drug to drug interaction with nitroglycerin that we talked about earlier. Okay, we could cause heparin-induced thrombocytopenia with the platelet. You have your antidote memorized. If I say that and it's not true, you have to fix that. Okay, so if I ever say, yeah, you have your antidote memorized and you don't, you have to make a little note and memorize your antidote. So the antidote for heparin, okay, heparin sodium is protamine sulfate. All right, so now let's drill warfarin Coumadin. Unfortunately, this is a high maintenance drug. It really is. Number one, it takes forever to get to a therapeutic range. High maintenance problem number one, okay? Number two, we need to monitor the PT-INR. You memorize those values already. Number three, there are food restrictions. You see the high maintenance problem? And we want to teach client, take this at the same time, okay, of the day, every day, because again, it has a thin therapeutic threshold. Test questions. The goal is not for the client to stop eating anything and everything that has vitamin K. That's not the goal. The goal is not to remove everything vitamin K in your diet. Okay, so let me explain. It takes 45 days to get the INR to be between 2 and 3 while they're on Coumadin warfarin. So whatever diet they were on during those few days is the same diet they need to maintain. However much of green leafy veggies, spinach, you know, whatever was part of their diet, during that time, they need to maintain that same level of vitamin K, which by the way is called aquamephetin. NCLEX doesn't use vitamin K, they use the word aquamephetin. So that's why you need these lectures. You need to go over it and know the proper terminology, because I've had students come back and say, what is aquamephetin? I'm like, that's vitamin K. Okay, so please, please, please keep that in mind. So again, Mrs. Jones, please keep your same diet while you're on this drug. Don't add additional, but don't reduce either. If you're used to having 3 salads a week, continue your 3 salads a week. Okay, so that's the mentality you want to have to get these questions correct. Okay, so some nursing interventions, we're always pulling that PT-INR, we're pulling liver function tests, we're pulling renal panels, right? For these clients, we pull them on fall precaution, reduce injections. We put lots of pressure if we have to, because they're gonna be potential to bleed. Okay, have your antidote at the bedside, always. If the drug has an antidote, have it at the bedside. Mrs. Jones, no more alcohol, no more NSAIDs. Please use an electric razor for shaving, right? Not a sharp, because again, the whole bleeding, any risk for bleeding, we're gonna avoid. The electric ones don't cut them. That's why we rather them use that. If they fall, go to the ER, because they might be bleeding internally. Okay, they should always have their medic alert bracelet on with these conditions so that when EMT comes, they'll know. Okay, and these drugs have to be taken same time every day. Unfortunately, there are some herbs that do not mix well with these anticoagulants because they do the same thing. They thin blood. Can you imagine being on 2 things that are thinning your blood? That's a problem. You need to know these herbs that do that. echinacea, licorice, the G's, right? Ginger, garlic, ginkgo, feverfew. Those are the herbal meds or supplementary medicine, complementary alternative medicine, CAM, we call them for short. They cause bleeding. And here you go on, you're on anticoagulant. That's a problem. Yep. And you need to know foods that are high in vitamin K, your green leafy veggies, broccoli, liver, very high in vitamin K. I did tell you this is a high maintenance drug, so you need to know a lot about it. So you were ready for all of this information. All right, so now those were anticoagulants. Do not mix them, right? Heparin, whether it be high molecular, low molecular, Coumadin, warfarin, those are all anticoagulants against clotting. Thrombolytics, although there are some things they have in common, the bleeding, are very different. Thrombolytics are clot busters. Okay, so I love the American Heart Association had this picture, credit to them. So TPAs, streptokinase, urokinase, their mechanism of action is that they activate plasminogen that causes lots of generation of plasmin. Plasmin are clot busters. They literally like annihilate them, destroy them, and make them tiny, 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 tiny. When they're small like that, they don't cause damage. Okay? So by dripping clot buster drugs such as TPAs, you'll hear us say all the time, streptokinase, they're TPAs, directly into the clot. So we filter a catheter right into that clot. Okay? And it just makes it tiny. And it doesn't block the pathway, which is great. So the early we can catch that myocardial infarction, you know, the greater. So that's why it's good to know the time of the initial symptoms, right? That's why we always ask the client, when did you first start, right? We need to know because there's a window of when we can do administer these medications. So we need to be within 4 to 6 hours of the onset of the MI. So keep that in mind. This one has a window. There are some diagnostic tests that have windows, meaning I only have this time and this time to do it, to administer it. This drug has a window, right? Epidurals have a window. That's what we mean by that. You only have this window of time to do it. You can't do it before and you can't do it after. This is an example of that. Epidural is another great example. If you've gone through the OB webinar, I teach that. Right, between this and this centimeter dilation, that's a window. Certain diagnostic tests have windows between this month of pregnancy and that month of pregnancy. That's what I'm talking about. There's some things have windows of when you can and cannot do them. So bleeding, obviously, antidote. Add that to your list of antidote. Aminocarpic acid, Amicar, is your antidote to your thrombolytics. Okay, I like this little mnemonic. I got to give credit to them. Heart and valvular plumping, deeper, kind of look like on the side selling hot dog type of thing, but it makes sense. And there's a few test questions here. If you've got a clot, vein or artery, just run these IV and watch them increase perfusion, decrease viscosity and aggregation in red blood cells, activase, TPAs, streptokinase, right? We just covered those. Our clot busters work. Yeah, they do. We want to administer them immediately after an event for the best outcome. Your window is 4 to 6 hours. Okay, you're going to watch out for bleeding, oozing if they have IV site. Yeah, that's going to happen. Okay, so great for your pulmonary embolism. That is the treatment. Okay, arteriovenous occlusions, thromboembolism, nice visual for those of you who are visual learners, you know, great. And here's really what's happening. You see, you could start off like this. That's huge. There's no blood flowing past that. And then you give the TPA injection and it breaks them down. And now that opens the pathway. Okay, so I think you should be good with your thrombolytics. Okay, couple more medication, then you can take another breather. your antiplatelets. Okay, so a lot of these you're familiar with Plavix, you're familiar with aspirin, but know their generic name. Okay, clopidogrel is Plavix, but you're probably more familiar with the term Plavix, but change that, be familiar with clopidogrel. Okay, your generic name, be familiar with dipyridamole. You got to say that one slow. Dipyridamole, or sometimes it's di. So be familiar with those. Ticlopidine, because those are the terms they'll use rather than Plavix or, okay. Now, how do they work? They all have the same mechanism of action, which is great. They're going to stop, inhibit aggregation of platelets. That's how they cause that thinness, okay? Which causes bleeding. That's just the way it is. So we're going to use those prophylactically, using the prophylaxis of long-term maintenance, go home in, right, type of thing. Complication following an MI. So following an MI, you'll see prescription of these for long-term, not just a month or two, long-term. Use prescription. Okay, coronary vascularization and thrombolytic CVA or thrombotic CVA, bleeding, bleeding, bleeding. The family of antiplatelets cause GI problems, so always educate people. Take this with food. A lot of antibiotics too cause that upset stomach, like, that nausea, that feeling, nauseous feeling. Mrs. Jones, take this with food when you take it. Don't take it on an empty stomach. And that kind of reduces that little problem. There are a few contraindications, and you imagine bleeding is one of them, but there are a few more. If they're asthmatic, right, they're diagnosed with asthma, they're allergic to or sensitive to NSAID, because that's part of the family. Any history of GI bleed, this is not the drug for you, because they cause bleeding. Bleeding disorders, not the drug for you. Test question right here, and you knew this one. You must stop these drugs, the whole family, doesn't matter which one. Okay, so these drugs must be stopped at least 10 days before invasive procedures, surgery, dental work, those type of things. And children, and by children, there's an age with this one, 15. Any child 15 or younger, especially after any type of viral infection, should not take this family of drugs. No aspirin, no clopidogrel, what's the other one? Mylanta has that stuff in there. None of that. It causes Reye syndrome, or sometimes you'll hear people say Reye syndrome. It causes like that, the lining of the meninges, and horrible disorder for the child. So that's a little test question right there. So a couple of test questions, okay, with this. Another thing you want to teach the client when they're on this family of drugs, on antiplatelets, they have to follow up with their hearing doctor, because there is a risk of them having ringing and buzzing in the ears, impaired hearing problem, dizziness. Okay, they need to report, but they should follow up with their hearing doctor like every 4 months type of thing. Okay, hang in there. Deep breath. Okay, cardiac glycosides. So this should be your top drug to go over to make sure you're well versed in digoxin. Okay, your cardiac glycoside, the most important drug here for this category, or what we're talking about, is dig. Lots of questions with digoxin, okay, lanoxin, or digitoxin, which is Christodigen. So great drug, just lots of questions on it. So wake up for me, deep breath. You need to know how dig works. What's the pathophysiological, what's the mechanism of how it does what it does? How does it help the heart work better? That's why we're giving this drug, right? So digoxin increases inside intracellular calcium. That is the electrolyte that it increases. Why does it increase that electrolyte? How does it do that? Why does it do that? What's the mechanism? So you need to remember that digoxin increases the intracellular inside, right? Calcium, that electrolyte. There's another electrolyte we're going to talk about in a moment that's important, but as far as the mechanism of how this drug works, it's with the calcium. It's going to cause the heart muscle fibers to contract better, more effectively. Okay, by producing something we call positive inotropic and negative chronotropic action. That's how it gets the heart to contract better, just not harder, but better. But it's via that calcium that is floating in the inside of the cells. Great for congestive heart failure, which we're going to talk about, atrial tachy and atrial fibrillation, which we've already talked about. This drug has a thin therapeutic threshold, meaning somebody could get toxic on it real quick. So this is a drug that's a little bit of high maintenance. We must monitor the toxicity or the level, the therapeutic range of this drug within the client. You need to know how the client presents when they're toxic on DIG. This gets a little complicated, so wake up for me. One of the common causes of DIG toxicity is hypokalemia. Low potassium causes DIG toxicity. I'm going to show you the mechanism of how that happens so you understand and don't forget, and you can get all of your questions correct. But that's one of the common causes. So that is an electrolyte that we are monitoring whenever somebody's on digoxin. It's the potassium. I need the potassium within 3.5 and 5.2. You have that memorized. Some books will say 5.0, 5.1, 5.2. So just memorize that range, right? But how do they look when they're toxic on DIG? They're nauseous, they're vomiting, they don't want to eat. They have this halo vision thing they're describing to you. They're confused. They're brady, not tachy, they're bradycardic, and they're at risk for heart blocks. You're going to see that on your ECG. Again, nausea, vomiting, halo vision, right here. Halo vision, confusion, bradycardiac, and heart block. You are always holding this drug if the pulse is below 60. Always, and notifying the physician. Hypothyroidism and hypokalemia is going to cause toxicity with this drug. It has an antidote. Digibind. Sometimes you'll see digifab, same thing. So if they have arrhythmia due to DIG, right? The arrhythmia is from that. That's the cause of it. Phenytoin is going to be administered. Okay. I'm not done. And I'll recap. But deep breath for me. So your cardiac glycosides, they're going to slow atrioventricular conduction to improve the cardiac output, make the heart work better, improve how the heart contracts without overworking it. Great for heart failure, ventricular rate, AFib, A-flutter. Ready for bradycardia, heart blocks, dysrhythmias, muscle weakness, nausea, vomiting, anorexia, especially if they're toxic on it. Now, digoxin is for atrial fibrillation and atrial flutter. Atrial, 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 atrial. Contraindicated with ventricular. Not mix that. One more time. Digoxin is for atrial problems. Atrial fib, atrial flutter, not for ventricular. Not for your heart blocks. Not if they're hypokalemic. Remember your contraindications. DIG, AFib, A-flutter, not ventricular. Not your heart blocks, not hypokalemia. Okay? So always monitoring their heart rate. I know the potassium, I'm not done talking about. If the heart rate's below 60, you're holding it and calling the physician. Okay, always. You're memorizing the therapeutic range for digoxin. There aren't a lot of drugs we ask you to memorize the therapeutic range for, but this is one of them. 0.8, some books differ a little bit to 2. You're memorizing that. You're memorizing that. Memorizing your antidotes, digibind, digifab, all the same. Client teaching. Avoid St. John's wort, licorice, ginseng, the herbs again. You're going to see me mention that within a few conditions. Not all of the conditions have the whole herb watch out thing, but for these, yes. Okay, St. John's wort, licorice, ginseng. We don't want these clients gaining weight. It's not real weight gain, it's fluid. Now, let's talk about the pathophysiological process or the mechanism of why the client gets toxic when they're hypokalemic, right? So if you're ever giving a diuretic or an antihypertensive that causes hypokalemia, they cannot be on DIG at the same time. Okay, so DIG and potassium compete for the same ATPase pump. Literally, they bind to the same ones. So imagine, look at right here. You have a bunch of DIG right here. Look right here, I'm circling. You have a bunch of DIG and you don't have enough potassium. So this would be a hypokalemic client. Too many of the DIG is gonna bind to whatever receptor there is. So then they're gonna be toxic on the digoxin. It's like you overdose them. You need the potassium to be between a therapeutic range so you don't get toxic on the DIG. So one more time, digoxin and potassium compete for the same pump. If you have too much DIG and not enough potassium to bind equally to these pumps, too much of the drug binds to the receptor and then they get toxic on the drug. That's why you always want a potassium level within a therapeutic range whenever a client is on digoxin. I know we've covered quite a bit. I need you to try a few questions so I can see whether you understand. Okay, so this one is in a learning mode. So it's right here, so let's learn because it's a higher level and so I did it that way. The nurse has finished reviewing the shift report on a client on a cardiac unit. The nurse should plan to see which of the following assigned clients first. So they'll give you 4 clients. So this is a client with hypertrophic cardiomyopathy who's reporting dyspnea. This is a client with cardiac catheterization who will be ambulating for the first time. This is a client receiving antibiotics for bacterial endocarditis who's reporting anxiety and chest pain. And this is a client who is recovering from a coronary artery bypass who has a temperature of 101. Okay. Your most critical client here is the one reporting the anxiety and chest pain. I just told you earlier, you always want to put these clients first, but let's go over why. Okay, so you have a client with endocarditis, they are at risk for thrombus formation. So this is the inside lining of the heart and it's inflamed. They're at risk of clot formation. I'm going to cover that condition in a moment. So the chest pain and anxiety, they have a pulmonary embolism. Those are signs and symptoms of that. So this is life-threatening. That client should be seen first. Okay. The dyspnea client who has a chronic symptom with hypertrophic cardiomyopathy, that's expected, right? Chronic symptoms of that. We're gonna monitor them, okay? The temperature client, yeah, we're gonna look into that, but that's not gonna kill somebody right away. With the cardiac catheterization, they're gonna ambulate with you for the first time. There's nothing wrong with this client. So number one is expected, nothing wrong with this client. The temperature is not gonna kill them right away. The chest pain, reporting anxiety, this condition puts them at risk. Okay, so the client that needs to be seen right now is the endocarditis reporting the anxiety and the chest pain. So this is a great example of all this chest pain stuff we've been talking about. Try this one for me. And you're gonna get it right. I'm not gonna lead you this time. So a client is caring for, I'm sorry, a nurse. The nurse is caring for a client diagnosed with CHF. And they're on digoxin and furosemide. What electrolyte would the nurse need to monitor closely? Okay, so definitely the potassium we are going to talk about, the diuretics in a moment, and you're never gonna mix them anymore. So you always want to know with the diuretics which electrolyte they hold on to and which one they waste. So this is an example of what's coming up, okay? So I do believe you need a breather, you need a brain break. So let's go ahead and take a brain break. Let's pause, right? Get something to drink, a snack, and come right back. All right, so we are going to pick up with the anti-lipidemics, okay? Or anti-lipids, sometimes you'll see. So you're familiar with these as well because there's so many commercials about them. But unfortunately, what I would love to change when it comes to the commercials, I wish the commercials would use the generic names instead of the brand names. So you're more familiar with the brand names, but you have to change that. But the good part is with the brand names, not all of them, Zetia is a little special, but most of them end in the same suffix. Statin, 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 statin. So the moment you see statin, you'll know it's an anti-lipid. Zetia, unfortunately, is a little bit different. Zetia's generic name is ezetimibe. Okay, so it's not a statin, unfortunately, but we'll take some rather than none. So your anti-lipids, if we're speaking layman's term to each other, it's a cholesterol lowering agent, and that's what it's going to do. It's going to lower your bad cholesterols, okay? So your cholestyramine, your cholesterol, your lovastatins, right? They're cholesterol lowering agents. So depending on which one, I don't see many questions where they're asking about the mechanism of these so much as with the antihypertensives, the DIG and stuff. This is a little bit different. I don't see many questions on those, but just for your FYI, they're going to interfere with cholesterol synthesis, as well as they decrease the lipoprotein and the triglycerides. But I wouldn't spend too much time on that. I don't see many questions on those. But the entire family, it doesn't matter which one, okay, whether they're on Lipitor, Zocor, Crestor, doesn't matter. All of them, we need to monitor liver function while they're on any statin, okay? We want to do that. The other thing that's important to monitor is their fat-soluble vitamins. So if you remember, your fat-soluble vitamins are ADDIC. That's the little acronym we use, right? Vitamin A, vitamin D, vitamin E, and vitamin K are all fat-soluble vitamins. And here's why. We monitor the fat-soluble vitamins because as we lower the client's cholesterol, we are also going to lower the fat-soluble vitamins. So they need to be on a supplemental, right? We need to monitor it and fix that. It's coming. Okay, so whenever a client is on statins, or let's say anti-lipids, you're going to monitor liver function in the fat-soluble vitamins, ADDIC, A-D-E-K. Okay, and let the client know these things do cause some constipation, flatulence, cholelithiasis. So they want to be prepared for that. How do they do that? Stay hydrated, right? With the constipation, walk, eat things with bulk and skin and things like that to prevent the constipation, staying hydrated for the cholelithiasis, those type of things. Lots of fluid and fiber will help prevent that. So tell them they need to change, their lifestyle with that. So those are your anti-lipids, not a heavy questioning or lots of time spending like you saw with the Jackson, but still, okay? Spend a minute there. Okay, this is a nice little recap with the nitrates. So I've already brushed or peeled one layer with nitrates. Let me peel another layer, and this will be good repetition for you. That's why I love this, okay, because the repetition helps it stick to your long-term memory. Now, how do they work? Arteriovenous capillary vasodilation, okay, by relaxing vascular smooth muscle. So opening, it's going to open it. That's what it's doing, dilation, because the client really has some constriction, right? So we need to open. So we're going to vasodilate, and that's what these drugs are doing. Smooth muscle, decrease myocardial oxygen consumption, so the heart doesn't need as much O2. Decrease preload with venous pooling, decrease afterload by decreasing peripheral vascular resistance. So that's how it helps the heart work better and not harder. They come in many different forms. The one you get questions on the most is the sublingual, but there's also nitrobid, which is IV. Okay, it's going to be titrated according to the client's blood pressure. There's nitrodur, which are the patches. Okay, and remember with the patch, be careful because it's going to vasodilate you as well. Don't ever touch them with bare hands. You always have to have on gloves. Okay, nitrostat or the sublingual tablet, that also comes in a spray. You treat the spray and the tablet the same with the whole 5 minute, 5 minute, 5 minute. Okay, same way, whether it's a spray or tablet, same analogy. 1 spray, wait 5 minutes, 2 spray, wait 5 minutes, 3 spray. Okay, same thing. So we use them prophylactically, treatment, management, acute MI that we're talking about. There are some life-threatening conditions. Whenever you're vasodilating someone, that's a risk, okay? So you risk them going in a severe hypotensive state where their blood pressure, bottom out and they could code. Now, never, ever, 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 ever administer 2 vasodilators. And you have to teach the client to never take 2 vasodilators. Sildenafil, Viagra, and tadalafil, Cialis are vasodilators. Can you imagine? That client will quote on you with 2 vasodilators. Major, major problem. So never, ever, 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 ever mix these. And whenever you're vasodilating, expect a headache, right? Let them, because that's, part of what's coming. Very common with the headache, nausea, vomiting, dizziness, reflex tachy, posterior hypotension, expect those. These are contraindicated with anyone with severe anemia. Cardiac tamponade, we'll talk about in a moment. Cerebral hemorrhage or trauma clients, we're not going to give those to. Hypovolemia, not enough, right? Hypo, not enough fluid volume. Hypotension is going to make you hypo. They're going to go into shock clients. That's not the drug for them. Okay, those are your control indications. So a little recap with your nitrates. Okay, we already mentioned isosorbate, nitroglycerin. We've talked about too much. So they're going to produce vasodilation, okay, which is great to open those coronary arteries. Great for angina, which we've already covered. That's how we started to talk about nitrates to begin with, because of the angina pectoris, the pain, because of MI, any type of peripheral arterial occlusion, because it's going to open it. Expect a headache. Expect orthostatic hypotension. So any client on these drugs, Mrs. Jones, do not get up without me. And you have to teach them. They go from a lying position, supine, and then they sit up. They stay there for a good 5 minutes. Let the blood flow. Let, get some normalcy. Don't just go from lying to sitting to standing. You're going to get dizzy and fall. So even from a lying position to a sitting position, wait 5 minutes. From a sitting position to a standing position, wait 5 minutes. If you go boom, 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 you're going to fall. Yeah, because that orthostatic hypotension is going to happen. So teach them these things, okay? Now let's talk about some specific nursing consideration when it comes to the patch, when it comes to the sublingual. So these are specifically, okay? So let's address the patch first, transdermal patch. It is always applied to hairless areas. If you put it in a hairy area, that is just not gonna help. And you can't shave the area to put it there either, because then you open all these sebaceous glands, the drug is gonna seep into the client too fast. So you don't wanna do that either. So apply the patch to hairless area using a new patch in different sites every time. Don't take it out of one and put it in the same spot, okay? So it's removed every 12 to 24 hours. We also have something we call a patch free or a holiday free, right? So we allow the client to be patch free for 10 to 12 hours each day, because then they become tolerant to it. And that's a problem. It's as if it's not gonna work. We don't want that. Sublingual. So we always check BP before we do these, right? BP, heart rate. If the client's mouth is too dry, that's going to inhibit the melting, right, of the drug. So give them a sip of water to stop that dryness, because it's just going to stick to under their tongue. It's just going to stick under their tongue. Okay, so sip of water, moisten it, and then put it under their tongue, and tell them not to swallow at that point, right? It needs to melt and then go in. If you look at under your tongue, lots of blood vessels. It's going to get into the blood vessels real quick. Okay, we've already gone over the administration, but let's recap. 1 tablet for pain, and you repeat it every 5 minutes for up to 3 doses. If the pain is still there after waiting 5 minutes, waiting 5 minutes, waiting 5 minutes, a total of 15 minutes, you need to be in the emergency room. That's the answer to that question. Seek medical help. If they're on the phone type of question, call 911 to their address. Okay. These tablets expire. So when the client feels that stinging, burning sensation, that's a fresh tablet. Don't swallow, Mrs. Jones. Okay. If it's sustained release, we don't crush them. You already knew that, like extended release type of thing. These are tablets that should also be kept in a dark container. Like they come in this special dark bottle. Then they cannot be exposed to sunlight. And the expiration date, by the way, is 6 months. Okay, so every 6 months, the client needs to replace those right here, 6 months. Okay. So let's recap. This should stick to your long-term memory. Okay, we're monitoring blood pressure, heart rate, EKG. Then the hospital, yeah, they're in an EKG monitor. We're monitoring their pain. And if they're on heparin, Coumadin, lots of teaching, lots of monitoring. Okay, we're monitoring toxicity if they're on DIG. Okay, before we give them the meds, we want to moisten their mouths. And clients like that should not be drinking anymore or smoking anymore. None of that. That kind of goes without say. You know that. The spray you treat just like the tablet with the 5-minute wait. All these class of drugs will cause orthostatic hypotension. So fall is a problem. Teach them how to properly go from a lying to sitting to a standing. And keep the tablets in a dark container. They should be away from light, moisture, body heat. The person shouldn't keep it on them or in the car or anything like that. They rotate the patches. Don't ever touch the patch with your bare hands. You must have on gloves, and you don't just throw them in the garbage, because the cleaning person could touch them and it's going to vasodilate whoever it is. It doesn't know you're the patient, the client, nope, it's just going to vasodilate. So you want to wrap it, in a plastic gloves before you just put in the garbage, so that if another person touches that garbage, they're not touching the actual medication. Okay, those are all test questions. And don't forget the nitrate-free period that we give them. Okay, I know that was a lot. We're almost done with that topic. We're not done. Now, we were talking about acute. There are some medications that are for preventative, for maintenance. We need to talk about those. Okay, so your isosorbids, okay, there's isosorbid dinitrate and there's isosorbid mononitrate. Okay, so let's go over those two drugs and the difference. Who do you use which one for? Both of them are going to vasodilate. Okay, doesn't matter if it's dinitrate. Let me show you cursor. If it's dinitrate or mononitrate, they're both going to vasodilate. Okay, they relax arterial and venous smooth muscle to open that, more blood, more oxygen goes through. They help the heart work better, not harder, by decreasing preload, right? Doesn't need as much. Okay. The heart doesn't need as much oxygen. Great drugs. Now, your isosorbate dinitrate, okay, find a way to remember that. Dino, I don't know how you're gonna, but find a way to remember. Dinitrate is used for both. Dinitrate can be used for acute right now in the ER, and preventative, go home and take, it could be used for both. Okay. But mononitrate is for preventative. This wouldn't be good for an acute right here, right now. This is a, take once a day. We may increase later, but yeah, you're not gonna give that if there's an acute attack right now. It's gonna be your isosorbate dinitrate. So please remember that, don't mix that. That's a nice test question because they explain to you where you can tell this is an acute, and then list of drugs. So it's your dinitrate for maintenance, preventative, go home and yeah, it's gonna be the mononitrate. Okay. All right, you should be good with those. Okay, drill enough. All right. Another class of drug that we've talked about, especially when we did the EKG, was atropine. So I need to mention a couple of things with atropine here. So atropine is an anticholinergic. Okay, that's a family. That's your drug class. Atropine falls under your anticholinergic agent. Atropine competes with a neurotransmitter, acetylcholine. Okay, we'll talk about acetylcholine again when we do endocrine. When do I talk about it? When I do myasthenia gravis under neuro, I cover this again. So it competes with acetylcholine for muscarinic receptor sites. It produces mild vagoexcitation, right? Because remember, we talked about atropine with the Brady clients. Okay, maximum we want to give is the 2 milligrams, but that whole family, your anticholinergics, there's a nice little thing that they do that you need to be aware of. So their action, how they work. Your anticholinergics, especially atropine, is going to compete with acetylcholine. Great for Brady conditions, which we've talked about. But here's the problem. They dry the client out. The anticholinergic effect, sedation, which you already knew, but the dry mouth, the constipation, the urinary retention, the orthostatic hypotension. So be aware of these common effects with this drug. So you have to teach the client. That's where the questions come from. You have to teach the client, Mrs. Jones, stay hydrated, right? Go through these measures not to get constipated. Teach them what to do, safety measures for orthostatic hypotension. Okay. And some of your adverse effect is bradycardia. I know it's used for bradycardia, so watch out for that paradoxical bradycardia that comes with that. It's a angina, tachy. So these clients have to be monitored on these drugs. But several questions, especially with the dryness of this drug. They should even suck on hard candy type of thing because it's coming with this drug. The whole family causes it. Okay, so we've covered quite a bit already, but we still have a lot left. So we're going to get into a different type of topic now. So we've covered coronary artery disease, we've covered angina, we've covered MI, we've covered the treatment, lots of drugs and teaching. It's a lot. So that part is over. Now we need to talk about infections of the heart. Okay, so if you remember my anatomy and physiology of the heart, I went over the different layers of the heart with you. So now we're going to talk about those layers getting infected, which are conditions in the NCLEX that you need to know about. And I know recently students who have had endocarditis, like last week, 2 weeks ago type of thing, wake up. All right, so remember I talked about the pericardium, the myocardium, the endocardium. If you haven't watched that, please go back, okay? Because that's important for this to make sense now. So different layers of the heart could get infected. It could be from different types of pathogen. It could be bacterial, it could be fungal, it could be viral. So a number of different pathogens. So let's start with peri first. Pericarditis, whether it's bacterial, fungal, lupus, MI complication, there is an inflammation, itis, in the pericardium part of the heart. Very painful condition. There is a whole positioning question with pericarditis. Okay, so they're going to have the chest pain with positioning. So this is the client. Do not lay them flat. The best position for this client is edge of the chair, leaning forward, like you're gonna do a thoracentesis on them, like that, okay? They need to be leaning over, leaning forward, nice C shape. They feel better when they're doing that. They have what we call a pericardial friction rub. The layers of the heart are rubbing together because of that inflammation. We're gonna pull a white count. We wanna see if it's an infection, if it's, you know, bacterial, we're gonna pull that white count. We're gonna pull their sedimentation markers. We want to find the underlying cause. What pathogen is causing this? If it's bacterial, they'll be on antibiotics, right? We'll put oxygen, steroids if there's edema. But another test question with pericarditis that I don't want you to miss. Whenever it's pericarditis, you need to have something at the bedside called a pericardial, hence the name of the condition in the kit, pericardial synthesis set. Why? Because these clients are at risk of accumulating fluid between the layers of the heart. This condition puts them at risk for that. So the moment you see it's pericarditis, you need this pericardial synthesis kit at the bedside. It's just a kit with a large bore needle in it. It's not even a complicated, nope, there's not even a lot in that kit. It has a large bore needle. I'll show you a picture in a moment. So that's pericarditis. Now, myo is the muscle, right? So there's an inflammation in the muscle of the heart. Could be viral, fungal, bacterial. Causes them to be very tired. They're out of breath. Lots of murmurs with those. We're going to pull the cardiac markers, put them in the EKG. Yep. So this one, same thing. What is causing it? We're going to need to look at the underlying cause. We're going to monitor their heart rate. They're going to be on digitalis. And we're going to watch and make sure they're not toxic on it. Not many questions on that one. Endo, yes. Endocarditis, very frequent with drug users, IV drug users and abusers. Yeah. Okay. It could be infectious as well. Now, the problem with endocarditis, remember that's the inside, right? Blood is flowing. Your valves, that's the big issue with that one. It affects your valves. When it affects the valves, it decreases blood from moving to where it's supposed to move. That causes clots, big, huge clots. And those clots cause the multi-system failure. Okay, we're gonna do lab work. We're gonna pull an echo. I'll show you in a moment. We're gonna find the cause. We've got to look at the underlying causes for these. They're gonna be an anticoagulants. I just mentioned clot. The moment I mention clot, you're thinking that. prophylactic antibiotics, we're going to talk about to death. So this is the first layer. Let me keep peeling this to get to the core of this thing, okay? So recap. Pericarditis, you know they're all inflammation, so I don't need to keep saying that. And you know it could be a number of causes. I don't need to keep saying that. Recap, do not put them flat. Very painful for them. Lean them forward. They'll know anyway. But for your test questions, they have the rubbing and they're at risk of accumulating fluid between the layers of the heart. But they're out of breath. They may have a fever, sweat, chill, depending on what's causing it. So they may have differences between their systolic blood pressure, their pulse wave, that's the pulses, paradoxis, fluctuations and abnormalities. The condition causes that. Diagnostic wise, we want to find the cause. It could be different causes. So we're going to do a lot of blood work. We're definitely pulling the white count. We're pulling the sedimentation rate. It's going to be elevated. If it's an autoimmune disease, that's why we may need to pull an anti-nuclear antibody. If we're thinking that's what it is. If they're diagnosed with this, you're going to see some ST changes. ST segment changes. We also do an echo. Okay. We want to see the pericardial effusion. We want to see, you know, the impact, the effect of this on the heart. We're gonna pull cardiac markers. Now let's talk about tamponade. Test question right there. Let me pause there for a moment. First, let me show you the picture. I'm gonna come right back. My visual learners. Look at all of that excess fluid. As this accumulates, pressure, that heart cannot contract and release in a normal way. Okay, so those clients are at risk of that. So that is a tamponade. So that pressure on the heart that occurs when blood or fluid gets into that space between the heart muscle, myo, and the outer lining, peri, causes a cardiac tamponade. The only treatment is to aspirate that fluid. Literally, the physician will stick a large bore needle under the guidance of an ultrasound and pull that fluid out. That's it. There's no other treatment, and they got to get it right between those layers and aspirate that. Okay, you know, as a graduate nurse studying for NCLEX, you cannot watch TV unless you're learning something that's going to help you pass your NCLEX. So there's a great untold stories of the ER with this specific condition. So there's these two sisters that come into the ER, and one of them walking, talking, and the other sister on a stretcher. So they started working with the one sister, you know, to revive her. Small town, small ER, and they stabilized the young sister. And then the older sister, who I guess was driving and had the car accident, all of a sudden became short of breath and collapsed. So they didn't know what was going on. It turned out that was what was happening to her. From that trauma, she started accumulating fluid in between the layers of her heart. And the physician had never done one of those procedures. I told you, small ER, small town. And the nurse said to the physician, have you done this before? She says, not on a real person, but she had to do it to save this girl's life. She did end up doing it, and then they transferred the young lady to a bigger facility that could accommodate her condition. But great stories, you know, they're true stories, and you learn a lot for NCLEX too. I love watching them. One of my favorite shows. It's called Untold Stories of the ER, if you've never heard of it. All right, so let's talk about management. Okay, so pharmacologically, it depends on the cause. Antibiotics if it's bacteria. Okay, steroids because there's some edema. Okay, so those are usually, yeah, for the pericarditis, especially if it's due to lupus or any client who's not responding to the non-steroid or anti-inflammatory drugs, the NSAIDs. Okay, we'll use the NSAIDs to help with the pain, the inflammation, or if they have a fever. You see, we're treating based on the cause and signs and symptoms. There isn't one, you know, specific treatment for this. It depends. Okay, but we're gonna avoid anticoagulants. Okay, because the anticoagulants may cause the cardiac tamponade to get worse. If it's blood, you can see how that makes sense. Okay, they're always on oxygen. They're going to need to have aspiration of that excess blood or fluid. So there's going to be an emergency pericardiocentesis done. Okay, if they have cardiac tamponade, excess fluid between the layers of the muscle and the pericardium, that's the treatment. Emergency, the name tells you pericardium, cardio, heart, okay, synthesis, removal of fluid, okay? If it's a reoccurrent thing, there could be a partial pericardioectomy, or a total, which is obviously a major big deal if you're removing part of. So our nursing intervention, we don't want to stress that heart. You kind of already know that. So pain control, anti-anxiolytics, keep them in a semi-Fowler. We want the best breathing position. The pericardiocentesis kit is right there. The moment they get admitted with a condition like that, the kit is there. Okay, so we want to observe them for any complications, any dysrhythmias, okay, any signs and symptoms of that cardiac tamponade, heart failure. We're always looking at their respiration. This is a client that you're one-on-one, you don't have a bunch of these clients. Okay, and we're always looking at the IV sites, rotating them, keeping them open. We may very well need large bore. They'll have a couple ICU clients too. They're not on a regular floor. That's a really sick client we just described. All right, so that was peri. Now let's do myo. Okay, so myo, you know, it's the muscle, okay, that is infected, whether it be bacterial, viral, fungal, rheumatic fever, lupus, a number of conditions. Again, you're gonna see the treatment is gonna base on the cause. That's just the way it is. A number, yeah, of epidemiology. So we want to find out the underlying cause. So how do they look? How do they present? Yeah, you figured out they're tired because this is affecting the heart. They're palpitating. Okay, this is not a comfortable condition. They usually do have a fever, but I've seen so many test questions on the murmurs with those. So lots and lots of murmurs with myocarditis, extra heart sounds, okay, S3 or gallops, friction rubs. So that's what you'll see most with these clients, okay? Congestive heart failure, left-sided signs and symptoms of heart failure as well. They're tachy, but not too many questions on myo. So we're going to, of course, do an EKG. We're going to pull the ESR, right? We want to see all that inflammation. We're going to pull the AST, the cholesterol, the CK. So it's like a regimen. And we're going to really look at the heart, and you'll be able to see that enlarged, that inflamed part with the muscle. That's a nice picture too, as you can see. Nasty stuff, but not too many questions on myo. There's just not. The murmurs is really what I see a lot, so keep that in mind. Yeah, lots of murmurs. They're very loud, extra heart sounds too with the myocarditis. Yeah, so other than that, not too many questions with myo. Okay, we treat them, you know, for hypoxia always. Anytime we're talking about heart, the impacts of the heart, yeah, we're going to put them on oxygen. And the treatment is going to be based on the cause. If it's a bacteria, same thing. You see, I sound like a broken record because it's just repetition. So antibiotics, if it's bacteria, steroids because of the inflammation, analgesics for the pain, they're always on oxygen. So similar analogy would be for, don't stress this heart, don't. We're assessing them for edema because this could lead to right-sided heart failure, left-sided heart failure. We're monitoring all the respiratory findings. You see, observe for findings of left-sided heart failure. So we're listening to the lungs. We don't want to see blood-tinged sputum. We don't want to see them out of breath because, yeah, this could lead to right or left-sided heart failure. So you're watching for that, okay? Lots of teaching. Yeah, we're always holding drugs if the heart rate's less than 60. So this is repetition stuff we've already gone over. And if it's a client who is going to be, living with this long term, then we don't want to stress them. No pregnancies, no alcohol. We want to do prophylactic preventative measures with vaccines, those type of things. Okay, so not much with those. All right, there are a few important things with endo, and there are a few questions with endocarditis. Okay, now endo is the inner lining inside of the heart, is where this infection is. Okay, the problem with this one that makes it so much worse than the others is because that infection affects the valves. Remember, when we covered the anatomy, we talked about the job of the valves. The job of the valves is to prevent blood from going back. We always want blood going forward, always. Now, with a messed up valve, whether it's stenosed or it loses its elasticity, where it's relaxing too much, is a problem. Endocarditis affects the valves, and that's our biggest issue. The effect of the valves cause thrombus. Infection leads to vegetation or abscess formation, with resulting thrombus and embolus, big clots. Sometimes from the endocarditis, it's classified as native valve endocarditis when the valves are infected or affected, and endocarditis in IV drug users, I mentioned, is common cause. Prosthetic valve endocarditis. This has a very, very poor prognosis, nasty condition. So especially if it's damaging valves, these clients don't live very long. Yeah. Yeah, and lupus, systemic lupus erythematosus, causes a non-bacterial endocarditis, nasty condition. I have to drill this a little bit more, so hang in there with me. This is a nice picture of what's happening and how nasty this is. It's gonna affect the valve, so that valve is not gonna be able to close and stop blood from going back anymore. And then blood goes back. You get the picture. So now let me show you how this affects every system, which is why it's so crucial and nasty. The murmurs, pericardial friction rub, anorexia, those are minor, honestly. I know they're bad, but they're minor to what I'm about to say. They have the little petechiae, you see right here. Lots of petechiae. But here's the biggest issue with this. Infarction of the spleen. Their spleen splits open. Okay, so they're gonna feel the pain in the upper left quadrant. Okay. Right here, if you see my cursor, see the spleen right there? So they're gonna have that pain right there, left upper quadrant. And it radiates to the left shoulder. Okay. And their stomach, their abdomen gets rigid, like, rigid, like board-like type of craziness. Their kidneys, infarction of the kidneys, open. There's gonna be blood in the urine, hematuria, pus, pyuria. Think pain, like in the back, you go, like you tap, very painful. Increase urine output. Function of the brain. Paresis, aphasia. They don't understand what you're saying. They can't get their words out. So they have like Broca's aphasia, where they're trying to say something is gibberish. Yeah. Neurological deficits. Infarction of the lungs. Cough, pruritus. You can see this is a critically ill client. Dyspnea, hemoptysis, blood, right? Peripheral vascular occlusion. So they get very numb, tingling sensation all their extremities until there's gangrene, clubbing of the fingers. How nasty this one is. Couple of test questions. There is a specific diagnostic test that is done with endo. So in addition to the history, the CBC, the cultures, the ESR, we're going to also do a transesophageal echocardiogram. Why? We need to see the valves. So this is a scope, as you can see in the picture here, large bore. It's going down the esophagus, past, the upper esophageal right here, and it's gonna get right behind the heart. So literally, we're taking a picture of the heart from the esophagus, from the back. See those valves. You need to see the impact of this condition on the valves. Of course, there'll be an EKG. You could see a lot with this one. Okay. So management, we're still looking to manage it based on the cause. If it's bacterial, antibiotics. And there's something else too that's extremely important here. Often clients will get an infection like this because they were not on prophylactic antibiotics before certain procedures, especially dental work. Do not miss this question. Prophylactic antibiotics before dental work and other invasive procedures. So anybody with cardiac history, right? History of cardiac anomalies for the rest of their lives before dental work or invasive procedure, they should be on prophylactic antibiotics. Because that's what happens, especially with dental work. You're introducing this bacteria into the bloodstream, and it could travel and lingers into the endocardium and cause this nasty condition. So if they have a fever, the antipyretics, the anticoagulants, we want to prevent embolism, of course, oxygen, and then worst case scenario, they need to replace those valves. No other option. Okay. Yeah, that one's a nasty one. Sorry. Okay, so you should be good now with peri, myo, and endo, and you see how different they are. Okay, so let me just recap real quick. I can't help it. So I like to put things in tables. So I think this is a great table that kind of pulls a little bit of all three of them. Remember peri, there's a whole positioning thing. You need the pericardiocentesis kit at the bedside. With myo, the murmurs are a big deal. With endo, it's a system impact, multi-system impact, okay, where it affects the valves, and the valves need to be replaced, okay? All right, I know that was a lot. Okay, so now, this is a similar condition with endocarditis, but it's called rheumatic heart disease, and it also has a name of rheumatic endocarditis. You see there's so much commonality. So there's some things in common with rheumatic heart disease that is similar to endocarditis. But usually with rheumatic heart disease, they're usually caused by Streptococcus aureus, nasty little pathogen. So rheumatic heart disease, damage of the heart by one or more episodes of rheumatic fever, where the pathogen is group A strep. Strep is nasty, y'all. Strep and staph, Streptococcus aureus and Staphylococcus aureus. Ugh. Two nasty pathogens that cause a lot of damage. So we're always very aggressive with those two to prevent them from affecting your kidneys or your heart. Okay, so with rheumatic endocarditis, there's damage to the heart, again, the valves. That's why this is very similar to endocarditis. But usually with this one, we're dealing with strep. So, but same thing, once the valve is damaged, we're repeating everything I just said, which is nasty, as you can see. Rare, but real, okay? And preventable too, if we're aggressive. So here in this country, we have all these, treatment and modalities, but in third world countries, it's not as prevalent. So you see that more so in underdeveloped countries. So there's a little test question that I don't want you to miss. So there's something that happens with these clients called Osgoff bodies. That's these nodes. It's nasty too. But be familiar with that term. So they get these from the Streptococcus infection. They get these lesions, and the proper term for them, Osgoff bodies. Okay, so findings, of course, when we swab them, strep, okay, they come in with a sore throat, throat is red, they have lots of exudate, their lymph nodes could be swollen, they have a headache and high fever, okay, polyarthritis with the joints, they're warm and they're swollen, okay. They have these involuntary movement, they can't control it, okay, severe cases. They get this rash, see, nasty, on their extremities and the trunk, subcutaneous nodules and the murmurs. So that's another nasty condition, as you can see, okay? So we need to pull all these labs to diagnose this, okay? We want to pull an ASO, anti-streptozin titer, right? We're going to swab them. We're going to pull the ESR. We're going to pull the white count, even the red counts. We want to see the C-reactive protein. Are they positive for strep? Is one of the first things we want to look at. Pharmacologically, the treatment is going to base on what's causing it, especially if it's strep, then they're going to be on lots of antibiotics. They're going to be on oxygen. Don't forget, little question, you'll see this somewhere in my teaching, always teach clients to take the entire dose of antibiotics. We never stop midway, because the next time they need it, it won't work, okay? I'm sure you already knew that. So some repetition and silly little things, you know, we are going to treat this client like the other cardiac clients, don't stress their hearts. And if they're allergic to penicillin, we need to know that, right? We need to monitor their fever, be aware of some of these expected signs and symptoms. A couple more questions with those. I think you should definitely group this with endocarditis, okay, because of the similarity, okay, as far as test questions. Okay. Now we have to get into the valve disorders. So after we do the valves, we'll do a mental break, but deep breath, hang in there. So I've talked about a bunch of conditions that could affect the valves. So remember, we went over all 4 valves. We never want them either rigid, right? They're stiff, or where they lose their elasticity, right? We want them nice and firm, opening and closing like they're supposed to be, okay? But sometimes that doesn't happen. We have stenosis, okay? We have regurgitation. We have these conditions that, yeah, I'm telling you, we want to avoid. So the valve gets thick, they narrow, then they can't do their job, okay? That's a problem. They lose their elasticity, they're not really closing and blood is just flowing or staying and lingering, backflowing. That's not good. Every time the heart contract, we want them closing and opening when they're supposed to. So let's talk about them not doing that, okay? That's a major issue. So with these test questions, pay attention as to which valve, and now you can see why all of this anatomy and physiology that I spent time going over, why it matters. Because if you're not aware of which valve is, then we have a problem. You're not going to know if it's the right side or the left side that's failing. Okay, so pulmonary valve, if there's pulmonic stenosis, that would be the pulmonary valve. There's going to be obstructed right ventricular outflow, which will cause a right ventricular hypertrophy. Because remember, so here's the pulmonary valve. You can see my cursor right there. That valve is stenosed. So the blood is supposed to keep going into the lungs from that valve. It's not able to do that. So then it's going to go back to where it came from. It cannot move forward. Like you see here in this picture, it's going to go back. Where did it come from? It came from the system. It came from the organs. It's going to go back. That's usually from congenital, which we talked about congenital issues already. We talked about tetralogy of Fallot. You're good with all of that. It's rare in the elderly, but it could be from rheumatic fever that we just talked about, because rheumatic fever affects the valve. It could be from endocarditis, because endocarditis affects the valves. Okay, and if it's regurgitation, it's still the same side. So this would be a right-sided heart failure client. Now, if it's on the other side and it's the aortic valve, that's a left-sided problem. That's going to be all the respiratory, because think about it. If you look over here, here's the aortic valve. The blood cannot continue to go to the body. That nice red blood cannot continue to go to the system. It's going to go back. It came from the lungs. It's going to go back to the lungs. And that's why these clients are going to have the respiratory problems, because that's a left-sided heart failure problem now. So let's go over some of these signs and symptoms, how these people are going to look. So if we're talking right-sided, depending on the severity of it, you will see different signs and symptoms. So if it's moderate to severe dyspnea on exertion, they can't go up the stairs, they can't go to the mailbox, they can't do much. Paroxysmal nocturnal dyspnea or thopnea, they're weak, they're tired, they're palpitating. If it's severe, you're going to see cyanosis, peripheral facial cyanosis. Right-sided, they're going to have the JVD, jugular vein distension, which is you see here in this picture. So how do you assess that? You lay the client flat, literally flat, and then you elevate the head of the bed. And if they're in right-sided heart failure, this is going to pop out. They're the clients with ascites, with edema. My shoes don't fit anymore, my belt. Hepatomegaly, the liver, diastolic thrills. They're swollen. See, all of that fluid, it goes back. That's all right-sided heart failure. We're gonna do the EKG, obviously, the history and physical, the echo, cardiac cath. All of these are the diagnostic tests we would do for these clients, both right and left. For mitral, all the respiratory problems, right, which I just went over verbally, but I have a little side-to-side chart for you to compare. We'll go over these in a moment before we go into right-sided heart failure. So let's go back. So with the mitral stenosis, there's a little mnemonic. Now there are others. So if you have another one that works for you, keep it. You know what I mean? Don't change, whatever works. But they're gonna be on the diuretics. We want to relieve that pulmonary congestion. We need to decrease all of this fluid they're retaining. If their kidneys are working beautifully, that's not a problem. There'll be an oxygen, you already knew that. We're going to talk about the ACE inhibitors, the beta blockers. They'll be on a low sodium diet, because if you don't change that, you're not going to be able to get rid of that excess fluid. We don't want to stress their heart, so the whole exercise thing has to be as tolerated. Any little exhaustion, stop. They may need to have the valves replaced. May not have an option but to do that. And they may need to be on long-term antibiotics. So this is critically ill client, especially if we don't monitor this. Test question. We are always taking these clients' weight, daily, regularly, ongoing, because when they gain, it's not real weight, it's water weight. They're retaining fluid. Okay, we don't want them gaining weight, getting more and more out of breath, or topnea, tired. They need to gradually low sodium diet for a long time, what I call the nasty diet. And you know about the antibiotics. I already went over this question. If they're on anticoagulant, you see how the information repeats? Like, we've already covered this stuff. It just repeats and it helps stay in your long-term memory. So if they're on anticoagulant, especially on Coumadin and warfarin, we're gonna pull the PTIN on. We're gonna educate them on not over consuming food high in vitamin K, and they're gonna be on bleeding precaution. I want to go over this little table and you'll see why in a moment, because sometimes you get asked questions, you need to know the why we're doing the things that we're doing. So this is a little mnemonic to help you remember. I like to make my own. I don't know if you do, but if this works for you, adapt it. If it doesn't work, make your own. You know why we're pulling the Kim panels, right? We need to see if there's any type of myocardial damage due to some of these conditions. We want to look at the electrolytes, if they're imbalanced. We need to see the size of the heart. So we're going to do a chest x-ray. That'll show us if they're in right, left-sided heart failure, full-blown heart failure. We want to do a pulmonary artery catheter pack. That's going to tell us left versus right-sided heart failure. We're always monitoring INO. We need to make sure their kidneys are still working. If not, they may be retaining fluid. We're going to do an arterial blood gas, which I know I haven't gone over the details with that, but we will. And they're always, you know, getting oxygen and on a pulse ox. We're always monitoring the vitals that you knew. And I've already talked about the weight. We don't want any weight gain. It's not real weight gain. Okay. So now, whether it's right or left-sided heart failure, the client is at risk of going into full-blown heart failure. Literal. The heart fails to pump enough blood to support not just it, but the body. There's different types of congestive heart failure. It depends on which part of the heart is failing, but right could lead to left, left could lead to right. Okay, and you know the left half pumps to the body, right? And the right pumps to the lungs. So think about where the failures have, which valve, which ventricle, that way you'll know, is it right-sided or left-sided? That's why the anatomy made such a difference. So many causes, and we've talked about most of them already, not all, but most of them. We've talked about coronary artery disease. We've talked about myocarditis, endocarditis, pericarditis. It could also be collagen issues, which is what lupus is. Okay, scleroderma, dysrhythmias, we've already talked about. We haven't talked about hypertension, but we will. Hyperthyroidism is covered under endocrine. We've talked about cardiac tamponade. So you see a lot of these causes we've already covered that could cause the heart to fail. This is another recap of blood flow. So I did this, you know, when we did the anatomy and physiology, but this is something you need to understand in order to know what's going on pathophysiologically. And I do believe you need a nice, clear understanding of blood flow for next generation NCLEX. Okay, so let's just recap. And you see here, this is such a nice visual. Okay, let's start with one. Blood enters the left heart from the lungs. You know, that nice rich red, beautiful in the lungs. If left ventricles fail, blood backs up into the pulmonary circulation, which leads to fluid in the lungs. So the respiratory problem, the out of breath, the blood tinge. Okay, so all of that is left. Okay, blood leaves the left heart, enters the systemic circulation. Okay, imagine that here. You don't see the body here, but it's there. And blood from the systemic circulation enters the right heart. The right ventricles, if those fail, blood pulls into the systemic circulation, leading to fluid buildup in parts of the body. So that's why they're swollen. Okay, they have all that edema, excess fluid that they're accumulating. And blood leaves the right heart, enters the pulmonary circulation, and then you have all of this circle again, and it's every contraction. You can see how this impacts the entire body. Nice visual, those of you who are visual learners. Okay, I like this picture. Okay, so sometimes you get questions where they tell you the client comes into the ER and they say certain things, and then they ask you, what would be the next thing you would ask the client? That's the purpose of these couple of charts. So the finding is chest pain, pathoischemia, okay, to myocardial, which we just covered. So you, the nurse, would ask the client, where is the pain? What does the pain feel like? How severe is it on a scale of 0 to 10? What causes it or makes it worse? Does anything make it better? Does it spread? You see, you need to spend a moment with this chart, because based on what the client says or the findings, you have some specific questions you should ask. So one more time, you're going to spend time on this little table, and this little table. There's 3 of them, sorry. I'm just the messenger. But I want to show you what you're thinking of when you're going over these tables. So the client comes in, says, they're coughing at night. Okay, so we're thinking pulmonary congestion, especially if they're in a recumbent position. Okay, we're thinking left-sided because of coughing, right? We're thinking left-sided heart failure. Okay, so we want to ask do you have a cough? If the answer is yes, what do you cough up? Is it more at night? And we don't want clients coughing up blood. That's definitely, left-sided heart failure, severe congestion, pulmonary capillary. So let's do one more. The dependent edema, we see that, right? We know you're thinking right-sided. I think I've drilled right and left so bad now. Okay, so right-sided because of the edema. My question would be, have you noticed any weight gain or swelling in your feet, ankles, legs, and abdomen? If they're bed-bound, gravity is going to be in the sacrum, right? Gravity, they're not standing up. Are your shoes tighter than usual? Do your clothes fit you, especially around your waist? For the fatigue, how would you describe your usual activity? What is your current activities? What have you stopped doing because of this? Are you able to rest during the day? How often do you wake up at night, because of this? So you kind of get the point. You're going to do that with these tables. Okay. And that obviously may take you a minute, but it's important. Okay, so there's 3 of them to go over them. Yeah, I know you don't want to hear that. All right, let's try this question. You have an ambulatory client reports edema during the day in his feet and ankles that disappears while sleeping at night. What is the most appropriate follow-up question for the nurse to ask? This is not here by accident. I want to show you how the question is phrased, but if you study those tables, this becomes easier. I don't know which one they're going to ask you, so you have to spend time on all of it. So you have an ambulatory client who reports edema during the day in their feet and ankles, right? So we're thinking right-sided heart failure. It disappears when they're sleeping at night, especially if they elevate the lower extremities, bring all that fluid back to the heart. But the test makers want to know that the most appropriate follow-up question to ask this person. Is it, have you had a recent heart attack? Is it, do you become short of breath during your normal daily activities? Is it, how many pillows do you use at night to sleep comfortably? Or is it, do you smoke? You should be between 2 and 3. And had you read the little table, you would know the answers too. So as I mentioned earlier, these are findings of right-sided heart failure. Okay. Yeah, right-sided heart failure, which causes increased pressure in the systemic, right? Blood is going back to where it's coming from. So there's a shift between the interstitial space causing all of that edema. So gravity, right? During the day, they're standing up. The lower extremities are first affected whenever gravity we're walking. Okay, so this would confirm a diagnosis of activity intolerance and fluid volume excess, both associated with right-sided heart failure. Okay. Nice question. Yeah. So these come from the tables. All right, you kind of get the point. So now this is a nice comparison of right-sided, left-sided, and bilateral. So recap, okay? Right-sided, they're gonna have the nocturia, the JVD, which I showed you a picture, the edema, the system impact with the liver enlargement, which is hepatomegaly, abdominal pain, anorexia, nausea. That is all right-sided. Please, 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 please be very familiar with this. Let me tell you how this is gonna come to you on next gen style. Okay, which I made a case study just to see if you're good with left versus right-sided heart failure. So now you're going to pretty much be asked, you're going to get a whole lot of symptoms, right? Signs and symptoms. I could list all of these, mix them up, and then put left-sided, right-side, where you're gonna click, 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 whichever one it belongs to. So you have to be well-versed with this, okay? Left-sided, you're gonna see the respiratory stuff, right? Restlessness, irritability, hostile, agitation, anxiety, cough, crackles, pulmonary edema, frothy sputum, blood tinge, right? All the respiratory stuff. And if it's bilateral, tachycardia, hypotension, children won't want to play because, yeah, they'll be out of breath. So this is a nice little table you're also going to spend time with. One more thing you need to remember. Sometimes you get questioned testing to see that you know how to grade pitting edema. Okay, so right-sided heart failure client is accumulating all of this fluid, right? So we dip into their skin. We literally, we dip into it. We, yeah, push hard down. And we need to grade that. When it's mild, it's 1+, which is not a big deal, right? Not too big, barely noticeable, 2 millimeters, which is what? Very, tiny little quarter of an inch. And then their skin goes back to normal real quick, rapidly, not a big deal, mild, 1+. 2+ would be about 5 millimeters, quarter to half an inch. Takes a good 10 to 15 minutes. That's moderate. 3+ is a good inch. A whole minute is a long time. I mean, 10 to 15 seconds, not too bad, but minute, that's severe. 4+, 2 to 5 minutes, that's severe. Literally takes that long for the client's skin to go back to normal. So that's how you grade pitting edema, okay? Few more little mnemonics that you probably are familiar with. For the pulmonary edema, there's a little mnemonic, MDOG. Students use this a lot. Okay, for the pulmonary edema, morphine, diuretics, obviously, oxygen, and the arterial blood gas. So I like these little mnemonics, especially with what I see happening with next generation, with you really knowing how to treat these. So these little mnemonics, especially if you're nervous, they'll come to your mind. So yeah, there's a bunch. Okay, so we talked about cardiac tamponade with pericarditis. So let's finish up with that, and you might need 5 minutes, and then we'll resume. So fluid between the sac, the layers of the heart. That is a medical emergency. That fluid does need to be aspirated and removed. Okay, so our job as the nurse is to have the pericardiocentesis kit at the bedside. So you see, it just has a large bore needle that under the guidance of an ultrasound, the physician is going to put it right there. So when a client goes into heart failure, this could possibly happen as well. That's why it's right where it's at, after full heart failure. This is a possibility that this may need to be done for this client. So clients with chest trauma, aortic dissection, these are some of the causes where they may need to have this done. Okay, so couple of test questions must be under the guidance of an ultrasound. Our job is to just have the kit. We obviously don't do this. So afterwards, we want the client on bed rest. Have have to monitor them afterwards. There could be some severe complication, and there could be some puncture with the heart with this one. Nasty to have done, but keep that in mind. All right, so let's try this question. A client is admitted to the hospital with a diagnosis of left-sided heart failure. Okay. How should the nurse differentiate left and right-sided heart failure? Demonstrate distended neck veins in left-sided heart failure. Will distended neck vein be in left-sided heart failure? No, that's in right-sided. Present with crackles in his or her lung field with right-sided heart failure? No, that's with left-sided heart failure. Peripheral edema associated with left-sided heart failure? No, that's with right-sided heart failure. Present with dyspnea and crackles bilaterally with left-sided heart failure? Yes. So this is a simple way this question could come, right? Very simple. As you go down, 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 left, right, yeah. So this would really tell the test makers that, yeah, you know what's happening with right-sided as far as the signs and symptoms versus left-sided as far as the signs and symptoms. All right, I think you need a little mental break. Oh, okay. All right, everyone. So we'll call this part 2. So there's a part 1, part 2, and then part 3. So you have to, go over all 3. So enjoy, take a break, and then when you get back, start with part 3. We'll finish hypertension, antihypertensive, practice questions. Don't forget the next gen. So all of that is coming up in part 3. All right. Have a good one.